welcome everybody to this. This is my second board meeting, so I should know what I'm doing by now, but I think I feel less confident about this one than I did my first one, and it must be something to do with the hundreds of papers which we've had. So we've got a few subs today, and so we've got people on holiday, people unwell, etc. So I think if I get this right, we've got Johnny here for Joe. May not. Yeah.
Good morning.
Yeah. Hiya, Johnny. We've got Kirsty here for Gary.
Yeah. Hello, everyone.
Hi. We've got, and they may not have all joined yet, but I think we're expecting Diane, Joe and Val to talk around the maternity patient story. I know I've seen one of those names down, so I'm not sure if everybody's here. So welcome to you.
Morning.
Morning. Morning. And then our governors, we've had some ins and outs because there is a governors engagement event happening at HRI today in the foyer. Some people are doing that today instead of coming to the boards, but I believe we've got Stephen, and I have seen him, and we've definitely got Gina because I've seen her name.
Morning.
Good morning. And I don't think we have anybody else. Is there any other governor here who I have missed? No. Okay, so that's good. So that's who we're expecting. We don't have Andrea Gillespie on the freedom to speak up item. Some board members should have had a note about this yesterday. So we are going to leave. We left it on the agenda. We will just formally receive that paper today. But if you could just make a note of any questions that you might have had, let Amber have them. And Andrea is going to come to our November meeting, and we're going to give her those questions in advance so she can cover our points. We thought that was better than just deferring the item completely. So we'll receive the report when it gets there, but she's not here to present the paper, so we won't have a discussion about it, if that's okay. And then I think at some point Jason will be joining us for the agenda item around the staff survey. So he'll come in as and when. We've got formal apologies from Joe, Andy, Robert and Gary. Is that right, Amber?
And
Yeah.
Brian Moore, another public.
And Brian Moore, sorry.
Yeah, thank you.
Add him on another list. Okay. Anybody else aware of any other apologies that I've not mentioned? No. Okay, that's good. It's going to take me half the meeting to get through all this bit, all the admin. Right, so I think that's all our formalities. So has anybody got any interest to declare on any of the items on the agenda today that we need to be aware of and that we need to manage? Nope. So I'll take that as no. If something comes up during an item that you think, oops, I should have declared my interest there, just drop a note in the chat and then we can see it from there. Okay, it is a very tight agenda today, so we are going to have to, I'm going to ask presenters if they can do their best to stick to the time allocated, not wanting to stifle discussions, but we could be here till tea time if we don't keep an eye on some of this. And there is a private board meeting that it follows on immediately after, which has also got a full agenda. So minutes from the last time we met. I'm not going to go through them line by line, but if anybody has got any corrections that they would like to make on those minutes, having gone through them, if you could put your hand up and let us know what they are. So in the absence of Richard now, I did go through them with a really fine-tooth comb because I didn't want to let him down. The first meeting is not here. No, so that's good. So nobody's spotted any any errors on there. So that's really good. Thank you. Well done, Amber. And we'll sign those off as a correct record. So thank you very much. And then in terms of any actions arising from those, we do have an action plan. And on our action plan, we have a closed action that's been completed, which is the inclusion of updates around mental health, which we can also pick up when we get to that report. And then we have an outstanding action. It's an action that's not due to be completed yet until the 10th of November around the board assurance framework. So I don't think we need an update on those. Is there anything else from matters arising or the actions log that people would have expected to see? No? Okay, that's great. So we can sign off those from the last meeting. So moving swiftly on to the chair's report and then the chief exec's report, which I realised this morning I should have connected with Brendan so we don't repeat things. So I'll hopefully stay in the right area. So just to say, I've spent vast majority of my time since the last meeting. I'm still on my induction. I managed to join the COG from Spain. I've been meeting NEDs, execs, governors, and also starting to move through tiers of organisation, just on one-to-ones, picking up themes and things, and I will at some point feed that back in appropriately. I'm just waiting until I've got a bit of a story on there. We've had 2 Calderdale Cares Partnership Board. The first one was in public, and that was predominantly a governance type of meeting, but also Anna led a discussion there about the establishment of the Calderdale Provider Collaborative. And then at the development session last week, we were looking at the development of the strategy for Calderdale, but also the arrangements for quality in the partnership. And now at this stage, this feels quite officer executive type of arrangements, but if we look at what everybody else is doing around their quality groups and things in other parts of West Yorkshire, there may be a point at which non-executives become involved. So we just need to keep an eye on that, because there's obviously a capacity issue there with non-execs. I've also met Emma and from the Trust Charity, and Vanessa, who supports the governors, and had some really interesting conversations with them, particularly around engagement of governors. I managed to shortlist my first monthly CHFT. I love that acronym, I have to say, by the way. Being from Yorkshire, and I use it a lot, CHFT, but so they're really good. So that was great, getting some insight into those things. I've been dropping into committees. And then I've started to open out a little bit. So I've been talking to people in the places, leaders of the council, independent chair of the place committees. And then I'm also trying to build my network across Yorkshire and Humber, meeting other non-execs from other trusts. So I'm very internal, and then trying to expand a little bit out. So I'm still in sort of absorbing and learning mode. But for those who need to hold me to account for what I've been spending my time doing, that's what I've been spending my time doing. Okay, so I don't know if there's probably nothing I said there that requires any questions. So I'll hand over to Brendan for his update.
It's Vicky. Brendan's having some real IT issues at the moment, so Teams keeps throwing him out. So I don't know whether you want to come back to his item.
We will.
I think Rob's trying to help him at the minute.
Okay, right. Well, that's fine. We will return to that. If I forget, will somebody just prompt me, because I may well forget. Okay, so have we got everybody here for the for item 8? Because what we're trying to do in item 8, as you are aware, we have a patient story or a staff story at each of our boards, and what we've discussed certainly is about trying to align that story with our agenda, so that it's not sort of seen in abstract or in isolation. So on this one, we thought it would be really good to bring a maternity story that would demonstrate some of what we're trying to do through Ockenden and transforming and improving maternity services more generally. So if everybody's ready to do that, we can kick straight off with our maternity patient story.
Hi, it's Jo. Can you hear me?
I can, yes. So
Hi.
something to put up.
I haven't. I'm just reading, if that's okay.
That's fine. That's absolutely fine.
Okie dokie. My name's Jo Ambler. I'm one of the community midwives in Huddersfield, covering the south area. So anybody that knows it, Almond, Bray, Home Firth, Clayton West, all that sort of area. So me and my colleague Valerie met with Ellen Armstead when she was doing a tour of the building really one Sunday afternoon, once we'd been out to do some visits, and we were explaining about this lady who we'd seen and sort of how we'd cared for her throughout her pregnancy, and how it was actually a really good news story, and we were really proud of what we'd done. So this lady was a first-time mum, and they were first-time parents as well, which is quite important because that does open up a lot of different doors when they're first-time parents together. And this lady booked an appropriate gestation around about 8 weeks, so raising no sort of concerns there. However, when they both disclosed drug substance misuse to us. Very open and very wanting help to get through the pregnancy. And this is really good as a community midwife because straight away you're forming some sort of relationship and some sort of bond with them. Because I do that surgery, I did and saw them all the way through the pregnancy and worked with them. So if I was on annual leave, we altered their appointments and they were happy to do that as well. The basic background was that they moved to Huddersfield to escape, for want of a better word, issues going on in their hometown, and they wanted to have a fresh start and to give their baby a fresh start in life. They were already working under a number of agencies, so they were already working under the Drugs Support Network chart. They were working with the mental health services, and they were working with domestic violence. So basically, throughout the pregnancy, the bit that we wanted to highlight was that we worked as a multidisciplinary team. Social care were involved at times as well. But this couple was so proactive, asking for help, taking help on board, questioning if they were unsure of why we were sort of giving them the advice. And that was really good because they were just sort of saying, yes, Jo, we'll do it. We're saying, yes, why do you want us to do it? All through the pregnancy, they were providing negative cannabis tests, which was a massive, massive result for us and for them. And they were so happy about this. They were doing this right up to birth and after in the postnatal period. We went to see them at home for a birth plan, which is something that we don't do often, but obviously we can target individuals and give them sort of individualised care. And Valerie, who is my colleague, went out and saw them today. She would have come today, but she's actually in a clinic. And Valerie spent a lot of time with them, and because it was at a weekend, enabled us to give that time. And the bit where Ellen sort of linked in with us is that the couple asked if the partner could stop overnight to offer support because he was a massive support for her. And obviously in COVID, this wasn't able to do, and it isn't still. But what we did was pop it to sort of management in maternity, and through Ellen, she supported us as well to get him to be able to stay a lot longer. So to support mum and also to work with her and sort of bond with baby. It was very hard for Valerie at the time to be able to say, actually, no, you can't stop with her. But what we felt, because we got such a good relationship with the couple, is that we'll take this forward. And we were able to do that. The documentation from the hospital states that it was amazing. The couple were amazing with baby, didn't need sort of any extra input or anything like that. We then saw mum at home afterwards and provided continuity of care, so me and Valerie. So they sourced the same people every time. And now that we have transferred care over to the health visitor, baby is at home with parents and doing really, really well. So that's just our little story for you for this morning.
Lovely. That's a good positive story, and like you say, a good example of working with people who potentially there could be some vulnerabilities, but also that continuity of care. That's a good. So I'll just pause there for a second and just ask if anybody on here would like to just ask any questions or make any observations, and then we'll pick up just the general update if of anything we need to highlight to the board around maternity review and Ockenden. So, Karen.
Hi, Jo.
Yeah.
It's really good to hear that story, and it's so important that the parents were really working with you and very open and honest. How did you find that kind of need to join up with other agencies to help and support? So it was a whole solution as opposed to just you trying to, work on your own and work through the issues with the parents. Was it important to have that other support around you?
It was, and importantly in this respect, they were accessing some of the care already prior to pregnancy, so that did help. But yes, we met maybe once a month just sort of for a catch up with everybody, with the parents involved. So yes, it was important, but the fact that it was there initially prior was a good starting base for us.
Okay, thank you.
Points or questions or observations? Lindsay?
Thanks, Helen. So thanks, Jo. I mean, it really demonstrates, doesn't it, the complexity of women and families that our midwifery teams see at our different places, and some of that context to what they have to do in terms of managing those complexities and joining services up. So, and really working in partnership with both parents, but other services as well, and establishing those safe relationships is really important. So thanks, Jo, for sharing that with us. I think it demonstrates, the different changes in community midwifery that they've seen over the years, and the complexity of different women that are accessing the services.
Yes, I think that's a massive thing, that we're now seeing lots of more complex and more vulnerable women, and we are having to broaden our skill range, I think, as well, to be able to provide the care that they need and they expect.
Of course, we all know far too well what happens when that doesn't happen, when it goes the other way. So
that's it.
Diane?
I'd just like to say thank you to Jo and all the community midwives, because I know what a fantastic job they do, and I know how difficult and challenging it is at times, but this just demonstrates the fantastic work that they do each and every day, because Jo's got one case, but I'm sure she could share 1,000 cases that she's got the same outcome with. So thank you, Jo, from myself.
Thank you, no problem.
Okay, so any other questions or observations from anybody? In terms of the governors that are attending today, I am going to stop at different points and sort of give you an opportunity if there's anything you want to just points of clarification or observations. I did it at the end last time, but I'm conscious of the time this time, so I'm going to do it at little points in between breaks in the agenda. So if there's anything you do want to raise at certain points, just make a note, and then I will break and allow for you to do that. Okay, so are we okay to move on to just a general update for the board today on maternity services? I know we have this at each of our meetings, and it's obviously a bit, high priority area. So if you want to maybe draw things to our attention that we need to know, and Karen, I know you're very involved in this as well, so please feel free to chip in.
Thank you, Helen. So I'd like to introduce Diane Tinker to the board today, who, aligned to the Midwifery National Manifesto, is our newly appointed Director of Midwifery. So congratulations, Diane, and welcome to the board. We're going to provide, you've obviously had the paper, but we're just going to provide an oversight really of some of the service developments that are happening in maternity, and then in particular in relation to our response to Ockenden. So I am going to hand over to Diane, but in terms of executive oversight, we've got strong ward-to-board governance. We're working with a really passionate team who want to really focus on continuous improvement across midwifery services. They're proud of their teams and the service that they deliver, and they've a real ethos of one culture of care in terms of looking after women and families and looking after each other in that service. And they're committed across the MDT to learning and continued improvement, and Karen and I are obviously the board safety champions and have insight with the team on a regular basis, and we can see that in practice. So I'll hand over Diane.
Thank you. So just a little bit about our service first. We provide maternity services across a diverse population through Halifax and Huddersfield, so a large geographical area which is both urban and rural in nature. At the moment, we birth approximately about 4,500 births per year. We have a home birth as an option. Our freestanding at Huddersfield currently is suspended just due to our staffing challenges, but we have a co-located birth centre, and we have a obstetric-led birth centre here at Calderdale. We've got 31 beds combined antenatal and postnatal wards, and we have 4 designated transitional care cots. And obviously we're supported by a 20-cotted level 2 neonatal unit. Next slide, thank you. So just talking about, yeah, we do have a really good ethos within maternity about the one culture of care, and we've really took on board the 4 pillars. Next slide, please. So I'm just going to tell you about a few of the developments what we sit under each pillar. So we put the patient first, and put people first now is a new talk that we use. So we work closely with our Maternity Voice Partnership. So Maternity Voice Partnership is our service users. We have got a new chair in post who we're just going to start working with, but we have active involvement with our Maternity Voice Partnership. We've developed a debrief service for women, because what we know is that women often want to talk about the birth experience. So actually we developed a designated debrief service. We have a midwife dedicated to that. We've also developed a rainbow clinic. So this is ladies who've had a baby loss, any duration during the previous pregnancies. And what they are, they're seen by a consultant who's dedicated to that service, and also by our bereavement midwife. And actually what we're seeing now is we're seeing some rainbow babies born, which is a really good service, and the service is getting really good feedback because of the continuity. We've really got a really active health inequalities work stream, which is led by Kate Highway, our public health midwife. And actually she interacts with our Maternity Voice Partnerships because they've done some discovery interviews. This is for ladies who wouldn't normally feed back on the maternity services. Kate also got funding to actually start some English for speakers of other languages, and she's doing classes with both the partners and actually with the women. And actually she did a survey which was talking about cultural awareness, and actually we now put in a cultural training competency on our ESR. And Kate's also got funding for from Smoke Free Homes Yorkshire, and what she's done is now we've recruited to 2 MSWs who are going to be looking at providing smoking cessation for our pregnant women. So actually we're doing a lot within health inequalities. Next slide, please. We go see. So actually what we've been doing, we've actually successfully used development roles to actually recruit to our managers. So what we did, we had a labour ward coordinator who was in a development post, and since she successfully got into a substantive post. So we feel that's a way of developing our own staff. We've actually recruited 2 clinical midwifery educators. So we've got funding from HNS England to actually look at how you're going to keep recruitment and retention of your newly qualified staff. Some organisations have chose to put a band 7 in post who actually would oversee it. We chose to actually put 2 band 6 clinical educators in, so they actually work alongside as a supernumerary midwife with the newly qualified, and they're getting really good feedback on this. And when we get our newly qualified in September, October, they'll be working with them as well. We've actually appointed a band 7 professional development midwife who's leading on all our training. One of the standards of maternity incentive scheme is that we have 90% of our staff trained, and actually she's actually doing a great job with that, and actually we will achieve that target. What else have we got? We've got BSOPS. So BSOPS is a Birmingham symptom specific obstetric triage system. And actually what we know is we needed a tool that could actually you could use to triage your staff, your women in a timely fashion, and actually so that every woman is triaged the same. So actually what has helped us is, because we're an end-to-end system, computer system, this has really helped us. So it's a very visual display as well when you walk in. So now women are not triaged on first come first serve, they triage on need, and we're actually seeing great strides with this, and the staff really have took it on board and are actually finding it useful. We are one of the only two trusts in the region who actually deliver maternity acute illness management. So this is about getting your staff aware of acute illness. As what Jo alluded to, we're getting ladies come through with a lot more complexities, and that includes medical complexities as well. So actually this is a really great course that all our staff are undertaking. Next slide, please. So we do the must-dos. We actually undertake hot and cold debriefs following serious incidents. We feel this is really important for staff. We know that we do have serious incidents what occur in maternity, and what we find is doing a hot debrief at the time but a cold debrief within the first week actually really helps staff being able to talk about it. But what it also enables us as an organisation to do is there any learning we need to come out of it? So we talk about what we did well, but also what could have been better if, and then could have been better if we actually develop an action plan from it. So we're actually learning straight away if there's anything we need to, but it's a safe environment as well that staff can debrief. We have a really robust weekly clinical governance meeting, which is really well established, and it reviews all our clinical incidents. And then that escalates up through our governing process if they feel anything needs to come to an orange panel or an SI. We have a weekly view, and this is our way of sharing all our learning, any information, any new developments on guidelines. We do a meet the team section as well, and it's just a really good way of sharing with staff any news, what we need, or information or learning. It's sent out to everyone as an individual, but it's also used in huddles. And it's really developed over the time, and it's such an interesting read. I love getting it every week, and it's our governance midwife who actually generates that. We have an established multidisciplinary guideline group. So the guidelines review guidelines, the group reviews it, it's an MDT approach, and then them guidelines are sent through other processes, but that's really established as well. And we're always proactive in continuing to enhance our digital services with our dedicated EPR midwife. And we've actually got women's having access to their own records now. And we're looking at how we can share them records across the whole of Yorkshire. Because what we do know is some ladies book with us, but birth elsewhere. And so actually that's our next progression, is how we can share our digital elsewhere. Next slide, please. So we worked together to get results. We were one of only 6 trusts nationally who had a lead midwife for each baby count, which was a national quality improvement programme. So actually Jill Bellyby, our governance midwife, so she was able to share the learning with us internally, which was really good. We're actively involved in regional recruitment for newly qualified midwives. We've implemented a maternity bleep holder, and this is so that one person has an overview of the whole service, and it really helps with patient flow, it helps in escalation. We have a named midwife and obstetrician for fetal wellbeing. This was one of the Ockenden recommendations, and we're proud to say that they're doing a lot of good work about talking around fetal wellbeing. They do a lot of training sessions. We participate in multidisciplinary training. And we are really proactive within the LMS. Actually, we have representations on all the work streams. So we really are involved in that regional work as well as local work. Next slide, please. just thought we'd put this in because we put it in the paper. It's about the challenges we're facing in midwifery workforce at the moment. We are not currently up to our workforce model. We're not the only one. We know it's not only a regional, it's a national shortage of midwives at the moment. It was on the news only recently. So as you can see from this, we have a workforce model of 186 and we've got about 157 when we last did this. So we are short of midwives at the moment. But what we're doing, next slide please, what we're doing about retention and recruitment. So as I'd already just mentioned, we're actually actively involved in recruitment in newly qualified, and we have got some newly qualified members of staff coming joining us in September, October. We also are looking at international midwifery recruitment as well. So we have just put a bid in. Sorry if that's just heard some backdraft there. So we have put a bid in to actually recruit midwives. We put a bid in for 5 to NHSE. And we've done this off the back of the trust has really had success with international recruitment of nurses. So actually going to be utilising their pastoral support as well if we're successful in the bid. We've established our own retention and recruitment working group, and we're going to be developing a retention and recruitment strategy, because what we are aware is what we also need to recruit, but we also need to retain the staff we've got. As Director of Midwifery, I've been undertaking all my own exit interviews because I want to truly understand why people are leaving. And also it gives me the opportunity to discuss, is there any options I could do to keep that individual working with us at an early stage. I share the themes from it with appropriate staff and actually into the retention and recruitment working group. And as I'd already mentioned, we've got the clinical educators. So that's hoping to actually keep our newly qualified feeling secure and safe within the role. Next slide, please. So our journey to outstanding, because that's what we want. We want to be outstanding and we're on a journey. So what do we need to do to actually continue on that journey? We want to continue to foster the one culture of being open, honest and responsive. We want to work as a triumvirate and an executive team to support the whole maternity services. We have a multidisciplinary oversight. We've got engagement with our non-exec, which is Karen, who's on the call, and we have engagement with our maternity voice partnerships. And we've developed a maternity transformation plan, which actually is taking into account Ockenden 1, Ockenden 2, our staff survey, our maternity incentive scheme, and we continue to benchmark ourselves and continue to look at how we can improve and how we can become compliant in all areas. And we do truly welcome peer reviews and external scrutiny, and we embrace them and see them as opportunities to learn. Next slide, please. So this is just an oversight of the transformation plan, which I talked about. And what you can see is what we're going to do is it's got actions and you can see which are complete, which are in progress. And this is constantly under review. We've got a new process where it's going to have scrutiny from a corporate team once a month, but we review this probably on a weekly basis to see where we progressed and where we've moved on. So it is a constantly evolving situation. Next slide, please. So what I just thought I'd just do a couple of slides on is the 10 actions from Ockenden, which we were showing red recently, and what we're doing so you can see what we're trying to do to actually constantly improve. So one of them was about actually maternity voice partnerships involved in complaints. So we've got a new MVP in post and we're currently working with them to actually share the themes, trends and responses. So there's a lot of work going on around that. We should have a dedicated clinic for our multi-pregnancies, so twins, triplets, etc. We don't have a dedicated clinic, but we do have 2 consultants who lead on this. And we're looking at a dedicated clinic, and we have just got an ultrasonographer who's a midwife who's back from training with us. So hopefully we're going to then evolve that and she will become the dedicated ultrasonographer for that clinic. One of the other things is about in utero transfers, and it's about having the babies born in the right place. So actually we're a level 2 neonatal unit. So our actual thing is we should have babies should only be born with us greater than 27 weeks. So one of the ones is you should have a robust audit in place. We report all our exceptions anyway to the LMS. So we report any baby what's born with us less than 27 weeks with an exception report. And we are looking at how that continuous audit can actually come through maternity services as well with the neonatal team. One of the ones is around how during a resuscitation, the neonatal team should be able to talk with a consultant if they can't be on site. So currently the neonatal team are looking how they can progress solutions to meet that requirement. There was another one about neonatal practitioners should be able to consider increasing pressures to manage babies who they can't oxygenate appropriately at the time. That is currently under a local guidance review because it will mean a change in our practice. Next slide, please. One of the ones on it is talking around cover for your neonatal unit. At the moment, the recommendations are that you should have 2 registrars in effect, one to cover neonates and one to cover paediatrics. At the moment, we don't have that. We're just working through that at the moment. We've got an action plan is completed, and our mitigations at the moment is they have a consultant on call, but we have a twilight registrar to try and cover that gap, and it is work ongoing at the moment, and they're looking at putting a business case together for that. There must be, so the next 3 are all around psychological support, and this is an area that we know we need to strengthen, and we will be doing work in this at the moment. We're undertaking a review of our current pathways and what offer we have at the moment, and I'm really keen that we do strengthen our offer for psychological support for our ladies who come through us. And the final one is about conflicts of opinions, and it's talking about, so this is about human factors. Now, we do a lot of work, so even though we haven't got a policy, it's in the development, we do a lot of work around human factors on our multidisciplinary training, and we talk about civility. So that is, we feel we're doing some of that, but we need to develop a policy to be fully compliant. Next slide, please. So off the back of Ockenden 1, which was the first one, which was in December 20, they did 7 essential, immediate and essential actions that all organisations had to undertake and become compliant with. So on 28th of June this year, we had an Ockenden assurance visit from our regional team, our team of chief midwife, and she brought a team with her, and we was assessed against them 7 essential actions. The key highlights on the day were very positive. The staff found it a very positive experience. They actually enjoyed sharing what we'd done, sharing our developments. And on there is just, I'm not going to read them all out because they're there for you, but actually these were some of the highlights. So they picked out that our weekly review newsletter was well received. They picked out that we had a good training package in place and our compliance was good, and we had a good strategy, trajectory in place. And they talked about our good MDT working. So we was really pleased with that. We have, next slide please, we have just received the full report, and actually when the team came, they assessed us and they said that from their assessment of evidence we'd sent them before the meeting and on the day, they assessed that we were compliant and met all the compliant with all the 7 essential actions. So we was really pleased. We've only just got that report this week. Next slide please. So what were some of the Ockenden recommendations from the visit? It was talking about considering expanding the role of the MVP to incorporate in co-production with guidelines. We've already started that, because what she's done now, she's invited to our maternity forum, which is where we actually approve our guidelines. We're certainly getting her involved in guidelines. They asked us to consider the language used for women's choices. We had an outer criteria group, and they said that outer criteria makes it felt wrong to women. So we've actually already done this as well, because we worked with the MVP, we've got her to get feedback, and it's now called supporting choices. Again, they wanted the MVP with guidelines, which we've already said that we're doing that. Good evidence of audit and being responsive to incidents, and consider how claims can be fully integrated into this process. So I'm working with Sarah Mather, who's the head of legal, to actually look how we can start working that in and getting the feedback to staff. They said we need to consider a dedicated obstetrician for maternal medicine. That is going through job plan, so I'd hope in the near future that will be successful. To hear an AMRCD's working through that. Raise awareness of the NED, the non-exec and the safety champions. So we've done a poster which is being distributed to all areas, and Karen has actually been on our weekly view as a meet the team, and we're actually getting them all to go on the weekly view. And the trust should consider how maternity voice, the voice is heard directly at board by inviting the Homodom to present. So I'm here today, so I think we can say we've achieved that one as well. Next slide. So I'd just like to say thank you for your time. Thank you for allowing me to come and present to you. Really proud of the service we offer, and has anyone got any questions? Thank you.
Well, thank you. That's absolutely fantastic. Really, really comprehensive, really thorough, and great timely update as well on the visit. So it's great that you had the opportunity to do that. So I'm just going to bring Karen in as our sort of non-exec sort of champion in this area, and she can add anything that she wants to add. But that was brilliant. Thank you, Diane.
Thank you.
Thank you. I'd just like to congratulate Diane and her team, and I don't really want them to undersell this progress, this incredible progress that they have all made. And at the insurance visit, it was the atmosphere was really, really positive. It was great to see people pulling together and working together in a very, very positive way. And the actual report from that Ockenden Assurance visit really is a good news story, and how much we'd actually understated ourselves, which is often the case as human beings. We do actually usually mark ourselves down. But I think it's a really good news story. So I think when that gets through to the staff in the team, I think they'll be absolutely delighted. Well done, Diane.
Thank you.
Thank you, Denise.
Diane, thank you very much. Can I just add my my well dones as well? And actually, for me, what you shared this morning shows that our maternity services are in a very healthy place. And I just wanted to remind the board that you know, in terms of the governance, all the governance around maternity services, that the quality committee also provides quite a level of oversight, and the maternity transformation plan, Diane, you'll be bringing back to quality committee. Yes. At some point. And the other thing, very quickly, I want to say that I was delighted because I had some questions around the recruitment and retention strategy, because as we know, it's been well reported that, you know, last year was the highest number of midwives nationally leaving services across the country. But what I was really pleased to see is that, you know, you've got lots of things in place. I wanted to find out about the career conversations, etc., that's taking place to ensure we're doing as much as we can to retain our current colleagues, and you've got that covered, so thank you very much.
It is challenging at times. That's one of our biggest challenges at the moment, I would say, is our staffing position, but we're doing everything we can. I am also planning to meet with the second year student midwives to actually get their voice of how they feel we are. Is there anything we can do, because we want to encourage our second year students ready for next year to stay with us. I'm going to meet with the third year students who haven't took a post with us. They do work across Mid-Yorks as well, but just to see is there anything we can learn from them as well, which would actually keep them working for CHFT. So we're trying to do a lot of things. It is challenging, but we're trying.
That's brilliant. Thank you for that. So one of the things I was going to ask you, and I say if there was one even better if you could identify, other than more midwives, which would be an obvious one, what would it be?
Way.
If you just could crack something, what do you think it would be?
Do you know, I've never been asked that question before. I think, I'm not sure it's anything that we could crack, but it is something I'm taking through to Hard Truths tomorrow, is strengthening the areas we need to do. So what we do know from Ockenden, we need to strengthen bereavement support. We need to strengthen our governance, even though we have a really good governance I want to strengthen. So I suppose it's strengthening areas. And actually areas what will impact for women as well. So I think it's probably looking at the bereavement and the public health. Public health is such a massive agenda now. So I think it's I can't say it's a crack, but I think that's what we need to strengthen, is public health, bereavement, I would say.
Yeah. Okay, thank you. And Vicky.
Hi Diane, thank you very much for that information. It was a really interesting presentation, and it is really heartwarming to hear about all the work. I suppose the bit I just wanted to do was not ask you a question, but to just draw to the board's attention. You sort of breezed through the slide that was around the Ockenden action plan, and I was doing a quick calculation, and the number of actions that are on that action plan was well over 200, and we sort of breezed through it. And I think we just need to be aware as a board of the kind of pressure and scrutiny that places on you, and particularly the senior management team within the division, because it is massive. And Ockenden's not finished yet, is it?
No.
You know,
No.
so we're waiting for the Shrewsbury and having the Kent one,
Yes,
and there'll be more comes out, I am sure. So I think, you know, it's just recognizing that you're delivering all of that stuff within the context of that additional scrutiny, governance, you know, because all of those need returns, and they all need, you know, evidence-based collecting. And I just wanted us to have properly clocked that as a board. I'm sure quality committee members are very much aware.
Thank you.
Really good point, Vicky. Like you say, a slide just sort of doesn't always quite convey the amount that goes on behind all of those lines and numbers and actions and recommendations. Lindsay?
Yeah, I think Vicky's really captured that. It's really important that, and that where Diane talked about strengthening the governance, we are going to do that. We're looking at how we strengthen that so that the team is supported to deliver across all of those actions, because it's phenomenal of the amount of actions that are in those plans. So we are on with that.
That's lovely. Okay. Oh, we've got one more hand, Peter, and then we'll draw this to a close. Peter?
Oh, thanks, Helen. Sorry for coming in a bit late in the day there. Diane, that's fantastic. Just to reiterate, a fantastic presentation report. Thank you very much for that. I just had one question around incidents and complaints.
Yeah.
And you put in the report the numbers for June, July, and then the overall cases to date. Obviously, one incident and complaint is too much, but they seem quite low. Just to get an idea of context, are they reduced through time to where we are now, if you looked over a 12-month period, or are they more or less the same as they have been?
I know our complaints have reduced over the last year, because I've just done another report for somewhere else, so I did look at them. Yeah. Incidents, I think you'll find we probably the largest reporter of incidents within the whole trust, because we do report a lot of things. What just to highlight to us, so if we have a lady who, for argument's sake, has a shoulder dystocia or a PPH, that is a reportable incident, and all them incidents are actually reported and actually reviewed at our weekly governance process. So we have a really robust way, and actually we do know that our incidents are reported correctly, because what Jill, our governance midwife, is, she actually does a counter check. So she actually pulls all the incidents off our Athena and checks that we've actually put them through as incidents as well. So I wouldn't say our incidents have gone down. Our complaints have definitely gone down, but I wouldn't say our incidents are usually quite static.
Great, thank you.
Okay, thank you. There's also a few things in the chat, so you know, from Nicola, in terms of sort of, you know, she's seen some of this in herself in terms of her visits, and also Gina, one of our governors who has a particular interest in this area, sort of saying she's pleased to see the examples of the work. So if you get a chance to look at the channel, it's hard sometimes to do the presentation and the chat, but there are further comments in there, plus one from Johnny, I think, who wants to talk to you out of the meeting. Okay. So there you go.
Can I just take this opportunity, I'm going to leave, but to say thank you for you all for your time, and I've enjoyed sharing our story with you. Thank you very much.
Thank you so much for coming. Thank you.
Thank you.
See you later.
Thank you. Bye.
Okay, bye. So I think Brendan has managed to join us again via some means or other. So I'll just slip back and let him just cover off his chief exec report before we move on to the health inequalities update.
Thanks, Chair. Apologies, everyone. I'm slightly discombobulated by being late. Can say One Culture of Care is in practice. I've had a very discreet but urgent call from Rob Burkett, who's trying to get me sorted out. So but there's the evidence of One Culture of Care in practice. I'm a bit late now, Helen, I think, with some of what I was going to raise. I was going to try and set the context around the 3 Ps that we've talked about previously. So actually, the agenda today feels very much a here and now agenda, and that's probably right in response to what we're facing for our people, our performance, and how we spend the public pound. But it's incredibly challenging. But in and amongst all of that, we've got the enthusiasm, motivation, and energy of our colleagues. I think Diane captured what's happening in maternity services, who across the country are under the spotlight and the level of scrutiny that they've probably never witnessed before. But in and amongst all of that, they're still doing the right thing by our women and their families. And certainly, Karen, when you and I walked around, was it last week or the week before? I think that's what we captured, wasn't it? There was a can-do attitude and a can-do approach to the problems that we're facing. I think it's broader than maternity services. Our colleagues are facing operational challenges. Consistently, we're not seeing seasonal variation any longer. We've seen a sustained period of operational and clinical pressure, which Johnny and Gemma will talk through shortly in the IPR. But again, I think our people have rallied to the cause and have gone above and beyond. But that isn't sustainable, and I think that will speak to Suzanne's response later about how do we remain agile in our one culture of care response, and think about how we need to respond to the challenges our people are seeing, certainly around the cost of living, the energy challenges, all of the things that are causing, in my opinion, a constant level of anxiety for our 6,500 colleagues. We're also facing significant political challenge. I don't need to talk about it, but we know next week things will change. Over the next 2 to 3 weeks, things will change as we see ministers and civil servants acclimatised to new positions. Vicky will be reviewing our stakeholder map to see what that really means for us. It has implications for us as an organisation, but also as an organisation with a looming reconfiguration. Anna and I have spent time over the past couple of weeks talking to national colleagues about what's the next step in all of this, certainly around the political uncertainty. So, and in amongst all of that, there is the deteriorating financial position that we see across the country that is having an impact for us. We will see that, as will every other acute trust and every other health and social care organisation. But again, it speaks back to what are the 3 Ps? What performance are we really aiming for in the context that we're seeing? And again, I've asked Vicky to lead a piece of work that says we do really now need to take stock of our performance metrics, because we're just inundated with them. I think we really need a narrative as a board about how we steward our people going forward. We're asking them to report on every single thing at this point, and that can't be right. I think we need a different leadership tack going forward, and actually as a board, I think it will enable us to, I think I've often talked about listen to the silence but follow the noise, or indeed follow the silence, listen to the noise. So that's where we are, lots going on, but in and amongst the here and now of the agenda today, there are elements of our strategic thinking as Anna refreshes our strategy. And as I've said, I think as a board, we need to hang on to a sense of realistic optimism as we navigate our way through what are going to be choppy waters. It's probably a bit late in the day now for me, Helen, to start with that, but that was the context I was going to set.
No, I think that's fine, and I think thank you, and I think it's useful in terms of, you know, as I reflected on the agenda, felt very much in the moment for this board, and I know you and I have spoken, and I've spoken with others about sort of, you know, our role around the future, our strategy, our vision, our direction, and how we're going to, you know, and how we get the, you know, as our board agendas start become a future focused and not just sort of in the moment focused, and that's not about adding things to the agenda. It's about like being a little bit sort of more, I guess, reflective about what we need to bring to the agenda on a regular basis. So and I know we've got a board development session time out in October where we're going to have quite a bit of focus on that, and then think about how that changes how our board works. So thank you. So I've got to just go back to my who went up first. Karen.
Yeah, can I just ask, Brendan, you and I have had this conversation about performance metrics and the abundance of them. And I totally agree, you know, people produce these and spend time producing these when in reality perhaps they don't need to produce as much or as frequently. Where's the work up to on reviewing our performance metrics?
So in all honesty, Karen, I think we've had various conversations, certainly in the 7 months, 8 months that I've been here, but we keep hitting we need to report because of, or there is a new national initiative to report on X, Y, or Z. What I've tasked Vicky with doing is grasping the nettle here, because I think there are some key metrics that we will need to consider at board and indeed in each of our committees of the board. But it's to your points, I think we've got divisional and clinical colleagues swimming in data and information and statistics that they need to report on. We need to be clear. I think that the world has changed, so we need to be clear on what's our response to that. The ICSs and ICBs have got a clear set of metrics that they will be monitoring performance upon. I think we should mirror some of that whilst not losing the nuance of what do we want to do for the services we provide in CHFT. I think we need to be brave. I've said my conversation with Vicky is we can't wait on this. It'll need to be challenging and it will be disruptive, but I expect to see a much more slimmed down version of an IPR and indeed the metrics that we monitor at board. We can't keep having 300 to 600 pages of information that actually we're just wading through, because the one thing you do need to pay attention to, I think it would be easy to miss based on the volume that we've got. I work in the rule of threes. That's clearly far too brief. I think we should be looking at up to a set of 12 metrics, I think.
Yeah. Okay, that's great. Thank you.
But I think as a board, what I would say is I think I've asked Vicky to lead this because I think she will have that objectivity in her role as a Director of Corporate Affairs. As a board, I think what we'll need to see is a set of metrics that we will need to hold our nerve with and live with, and then test out whether it's informing us and influencing our leadership as it should. But I would argue the volume that we've got now doesn't make that easy.
I think we've become a bit of a slave to that sort of, I guess, when you see national guidance and national things that will say your board must be cited on, you must make sure your board is cited. And I think we've almost, from what I'm picking up in certainly my conversations, we've become a bit of a slave to that. And we're not taking a sort of a reasoned sort of considered look at that and actually, so exactly what does that mean, and exactly what does that mean in terms of what actually comes to the board, how we frame some of that stuff. And I'll hand back to Vicky because I know she's getting her head around some of this too.
And if I can just add that it's also about the frequency of what comes back to board.
Yes.
That's, you know, there are some things that we won't be able to get away from because that's what we have to do. And as you say, Brendan, it's really important that we're clear about what's important to us in making decisions, not just looking at data, but actually helping us make decisions.
I agree. Can I suggest, Vicky, just before you come in, we run with the performance metrics as we have them for November, but Vicky brings a recommendation alongside that as to what it could look like. I think I'm not suggesting we double run in November, but if we have a paper from Vicky that suggests what we could look at, let's do both in the November conversation. Helen, I think to your point, it's part of our board development conversation. The metrics should inform the conversation. We probably need to pick up a discussion around our conversations. You know, are we strategic or assuring ourselves in the board debate? But let's do a double run, I think, in November, if that's all right, Vicky. I'm saying it's all right, Vicky, but I just need to check.
Yeah, don't worry. I think that there's a couple of things for me. So absolutely, the performance report is massive, and I'm not sure we see the wood for the trees within it. And we really pull out the things that are our priorities and our key risks and the ones where we should be focusing our attention, that kind of what keeps you awake at night kind of question. I think there is a whole load of national stuff where they say the board needs to see this, but we need to use our governance processes, the trust and the routes of accountability and scrutiny that are available to us so that we're not seeing things duplicate times. So I've picked up this week, there's papers that go to quality committee, same papers go to workforce committee, and the same paper then comes to board. And that's not right, actually. We should be using our routes of scrutiny and assurance to enable us to free up the time so that as a board we can concentrate on exactly what Helen's described as the strategy and the things that we are accountable for as a board. The other element is obviously the world around us is changed, and folk out in the ICB are seeing data about us that I'm not sure we see clearly as a board first. And so we need to work through all of those timings about when things are going there. Now there will be times when that happens, and we have to accept that. But the things that are really important to us and are really our areas of priority and focus, we absolutely should be seeing first as a board and have had that opportunity to scrutinise and discuss before it's discussed about us in a different forum. So I think there's all of that to work through. Absolutely, we should be seeing the measures that they're seeing at an ICB, plus the ones that we know are important to us, but that shouldn't be a 300-page report. And we also, I think we need to recognise where we are in terms of pandemic business as well. So there are legacy items within the report that we need to do. And all of this is what we will work through as part of a discussion in the board development session in October.
I think just to that point as well, it speaks to Karen's point. We need to free our people up to do some of the things that they need to do, instead of being the slaves to report writing that we've got caught up in that hamster wheel, haven't we?
Thank you. That's all positive. I'm looking forward to that October session. Tim?
Yeah, just to add that I fully support that approach. I think, you know, if you're defining your KPIs, your really key performance indicators based on your strategic issues, and then the rest of it in terms of compliance should be just performance indicators and should be just by exception. And that's the area where hopefully we can get the digital guys to focus on automation. I don't know. But having that clear distinction of your KPIs, which should be strategically driven, and then your PIs, which are just about compliance, I think would be really, really good.
I think that's right, Tim. And in amongst this, I've had a conversation with the team this morning. Rob, your guys have been very helpful. I don't think we benchmark ourselves enough against regional or national performance. As part of our debate, we should be testing out where we are in the pack and whether we're leading the way or actually we're falling behind. Middle of the pack won't be good enough for us. I do think there's a benchmarking conversation in all of this that should influence the KPI conversation.
Okay, Nicola?
It was just to say I support the simplification, absolutely, because I'm still weeding my way through the treacle of all the figures as an associate NED in the meetings that I attend. But I guess I just wanted to kind of sell as well the idea that although we look at that performance hard data, let's always strive to triangulate it with the softer outcomes. So obviously I work in the area of patient experience, and all of the softer data that comes through to us, those stories, those thematic themes that emerge around communication, the info we get from the Health Watch reports. It's just to always, I guess, strive to triangulate that harder data with that softer information all the time to make sure we sell that true story of what's going on in the trust.
I think that's right, Nicola. I think, Ellen, I think you hinted at it. I think we're entering a febrile environment. Winter will be challenging, we know that, but actually so will spring, so will next summer. In and amongst that, it's how do we set the tone for behaviours, and I think to your point, Nicola, conversations. We're not using data as a blunt instrument. Actually, it should inform some of the other conversations that we need to have.
Okay, so thank you for that little impromptu debate, setting us up for our development workshop. Nigel, sneaking in there just before I was moving on.
Yeah, I'll be very quick. Just to echo previous comments, I was just going to say, subject to any potential conflicts with my new role as chair of audit, I'm quite happy to be, if you want any input from any NEDs in that review. I was previously responsible for performance management at a local authority not too far away, so if you need any NED involvement, happy to do so.
Thanks, Nigel.
Thank you very much. And so I don't really want to cut that short, because I do think this is really important for us as a board to really get our heads around this sort of, you know how we operate and how we perform. We're not just here to receive countless things to rubber stamp. You know, we're here to add value and drive this sort of strategy and direction and vision for the organisation, and we can only do that, I think, if we're served well by that type of intelligence. Okay, so we'll move on now to Anna and the health inequalities update, and then got a bit of background there.
Okay.
I think it might be Brendan and his iPad.
Okay, thank you very much, Helen. The report that's included today on the agenda provides an update on progress and activities in relation to the work we're undertaking as a trust to address and reduce health inequalities. Be quite familiar with the structure of this. It's set out against 4 key work streams that we're progressing, and they relate to how we work with our partners and communities to address and reduce inequalities, how we are improving the experience in maternity services, and Diane's already spoken about that. That's been very helpful, having that earlier on the agenda today and bringing to life some of the information that's set out against that work stream in this report. The third work stream is about what work we're undertaking to be able to reduce inequalities in waiting times and access to services, particularly targeting and understanding where there is difference in waiting times for people who live in some of the most deprived areas, from BAME communities, for people who have a learning disability. And we've been able to demonstrate that action has been taken to reduce that gap. And the fourth area is the work that we're doing to support the development of a diverse and inclusive workforce. Overall, across those 4 work streams, I think the report demonstrates that we continue to make good progress. We continue to attract recognition at national level for some areas of the work we're undertaking, but equally we are participating in forums where we very actively want to learn from other approaches and other organisations. So there are some positive developments that are outlined within the report, but as we continue to say, there's so much more for us to do. So I'll end there and happy to take questions.
Okay, so with Peter.
Thank you, Anna. Thank you for that. And I think this is quite a good example of what we've just been talking about, actually, because the report is it's always been quite slick, quite straightforward. We're not digging and spading our way through, 300 sort of pages of information. So I think that's fantastic. My question, Anna, was around the strategy moving forward, and I know that someone's coming to the group in September. Is that something that you see will come through to presumably main board, maybe November or whenever the time is right? I think it'd be really helpful for the board to look at that strategy, new areas that we'll be looking at moving forward, how we align ourselves with. I know we've talked about the core 20+5 in the past and going beyond that. So just to get a sense of timing around that strategy report.
So I think the timing that you've outlined, Peter, is that it is coming forward, I understand, to the next Inequalities Committee, a draft strategy. So that would work with that strategy then coming into board in November. I think it will also, that strategy should inform the structure of this progress report, beyond the 4 work streams where we've commenced work, made some real progress. I think there's a chance to refresh what are the key challenges and areas that we want to focus on, and then be advised about progress that we're making and demonstrating that progress going forward.
I suppose it would fit in quite well with the October development session as well, in terms of strategies that sort of seems to hang together quite nicely. Great, thank you.
Sorry, I'm just struggling to get my mute button off there. Karen?
Yeah, thank you. I've just got a couple of questions, really, Anna. I think this is good progress. One of my questions was actually quite into the detail. How do we monitor that AHP is actually delivering the social value that we asked of them? Do we keep a close eye on that? Because my experience in the past is that, you know, constructors do say this, oh yeah, I'm committed to doing this, and then there's never any follow through.
So the answer to that is yes, we do. We have a project board specifically around the new build of the Accident and Emergency Department that has a range of standard reporting requirements to provide both assurance and also for us to be able to manage any issues that are arising. Included within that is a reporting framework around the particular targets included within the social value action plan. We've placed importance in our programme on social value. It's one of our key benefits of the programme. I mean, there are many benefits of the estate investment and the service reconfiguration, but social value is one that's really important for our local communities, our local partners, and a key way to help support reduction in health inequalities. I'd be happy outside the meeting, Karen, to share with you some of that reporting information.
Yeah, I think that would be helpful for me. The other question I had was, we've got limited resources, and it's good that we're leading a lot of this and that we're involved in the, you know, the groups that we are involved in. But what is the ICB doing to try and bring this together and maximise, you know, the effect of using the limited resources we all have?
I'm not sure I'm fully able to answer that question, not because there isn't work being undertaken. There are a number of programmes of work at ICB level. There is also investment funding through ICB as well. But I think it's probably one, Karen, that particular question. Be happy to collate some of that information to be able to share with you and to come back on that.
Okay, fine, thank you.
There are actually quite a couple of really good videos on the ICS website around. They've had two health inequality sort of events over a 2-year period, when the second one sort of shows the impact and the improvement. They would be worth sort of, maybe if we could circulate the link to people, because it's quite a good way of it's quite an easy way of sort of being able to look at it. And there's been two big conferences that sort of demonstrate the different impact that's been had, so that'd be worth looking at. There's a lot of work going on, I would say, in the ICS around this, and opportunity for utilising resources, I think, to support some of the work that we're doing, you know. Suzanne?
Thanks, Helen. I agree. October development session's a good opportunity to discuss this. I just wanted to give a bit more detail on the workforce stuff, because what's in the report just pays scant reference really to the workforce health inequalities work we've been doing together. So the workforce health inequalities bit is inextricably linked with our inclusion strategy, and we've been monitoring our workforce health inequalities data for some time now. We're now at a position where we're very confident in the data that we've got, and it has been a really important data set to refresh our people strategy. So we've been using that now to look at all the things all the work we're undertaking, and we'll come on to later with staff survey and health and wellbeing. But we understand our colleagues better, so we know better in terms of what is going to work from a colleague engagement, pay, health and wellbeing, development, career offer, and we are now at a point where we can look across to our inclusion strategy, our RES data, our DES data, start to pull all that together holistically. One piece of news that I'd like to share with the board is on Monday we're going to be joined by a BAME fellow from the fellowship programme across West Yorkshire, and they're going to have a specific task of looking at that workforce health inequality data. They're also going to review our staff networks as well, just to make sure that we have got a more holistic view of everything that's going on. So I just thought I'd add that in, because there's lots of work going on. We'll pay reference to the cultural competency training in the other papers this morning, but we're looking at widening that out. So we're not just looking at inclusion, EDI in one lens and health inequalities in another. We're now really in a position from a workforce point of view to bring all of that together.
Thank you, Suzanne. That's preempted my my main question that I had, because it's certainly something I've picked up, just soft intelligence, as part of my induction around sort of our focus, our energy, our effort, particularly in regards to sort of EDI and its sort of support, you know, how that supports the broader approach to inequality. So that's good, and it'd be good. I'd quite like to get you know, again, maybe have a focus on that in a future inequalities report, particularly as sort of like things like, I think the RES is due for update this month, having looked at the one on the website, and the sort of EDS, getting back into the cycle, I think, around EDS and EDI post-COVID. I know some of this work slipped a little bit, but it would be good to sort of bring that as a bit of an update piece, maybe have a little bit of a spotlight on it at some point. Thank you.
Absolutely. Res went to Workforce Committee in August, but absolutely
right,
more focus, yeah.
Yeah, that's great. Thank you very much. So if there's no further questions on the health inequalities update, we will oh, Brendan, are you?
I'm so sorry. I'm a very technically challenged individual. So in and amongst all of this, Helen, so I think the EDI and the agenda, certainly around that, Jason and I, on behalf of Suzanne, have been involved with some of our national colleagues, certainly over the last couple of weeks, about the support package that's available nationally on this. I'm not sure that's clear yet, but we have put ourselves forwards to either test out initiatives or to think about what does that really mean in 2022 and in the context that we're operating on. I think the health inequalities piece, certainly to your question, Karen, it's how do we bring some of this together? We offer a community service over at Calderdale. That's been part of our ambition, to have a conversation that truly talks about what is our role in education, housing, employment that's broader than health in all of this. Our staff are our community are our staff. And I think the final bit, Anna, you may have mentioned this, I'm sorry, because I kept dipping in and out, was the work from the national leads that you've been involved in the last couple of weeks, and you've certainly got connections with Bowler, the national lead on this, who is due to come on site, well, has got a further conversation booked in with you, and is keen to come on site to see some of the work that we have done.
Thank you. I guess a little note of caution, I guess, from me, particularly around the whole wider determinants of health inequalities. Not that they're not important, but I think playing in our partnerships is really key. But there are lots of things in the NHS, not just us, but with our partners, that we can do to reduce inequalities. Look, way before, you know, because a lot of the things around wider determinants, you know, we're a bit player, aren't we? And we do our bit, but we are a bit player. And I wouldn't want us to go so far around the wider determinants that we miss the things that are under our nose, getting people seen and treated early, getting people the right medicine early, getting people the right, you know, the things that actually we can do and make a difference.
I think we need to stop talking about the wider determinants, to your point, Helen. They're just determinants of health.
Yeah.
And actually do what's within our sphere of control, and then look at what's within our sphere of influence. And I think, again, there's a round robin to all of this. The key to success will be through our workforce and our people.
Okay, thank you. Right, what we're going to do now, I'm going to try, if we can, do our recovery update and our financial summary, and then have a short comfort break. So those of you to wriggle in a little bit, if you can hold on for those two items, and then we can have a little comfort break. So I think we're handing to Johnny now for our recovery update.
Thank you. Morning all. My name's Johnny Hammond. I'm the Director of Operations for Medicine. I'm covering Joe on this item. So I'm conscious people have had the slides and we're tight on time. What I'll try and do is pick out the areas where we're doing well and where the areas where we're challenged, try and give a bit more detail so that people are conscious of the challenges and the actions in place. So if we could go down to the next slide, please, Amber. That's great. Thanks. So the slide that you can see in front of you on the left shows the activity against our plan in terms of numbers of patients on the waiting list and being seen. Sorry, the number of patients that have been seen, and then on the right it shows performance against our plan, but in percentage terms. So the overall plan, I'm sure people are aware, is that we hit 104% for this year, and as you can see, there's a spattering of red and green. The current shortfalls or particular challenges can be seen on the day case and the elective lines within surgery and FSS particularly. And I think it's been noted previously, but the surgical elective plan is backdated, and that was to recognise some challenges that we have with theatre staffing and some recruitment of ODPs and nursing staff, and therefore the internal plan is phased to be back-ended, so we have an increase in activity in the last 6 months compared to the first 6 months. As an example, we had 80 theatre lists available in April. There's been a gradual increase, and we plan to get to the maximum 139 lists per month from September. So some of that will play out in these figures, and we expect the shortfall in numbers to be made up through the back end of the year. In the FSS division, there's also challenges around day case and elective. That's slightly different in terms of the challenges. There is some challenges in terms of theatre capacity, but going forward, they've got some extra lists on the weekend and within the week. And they're also bringing gynae surgery to Calderdale from September, which is going to allow a greater throughput of patients and also support the greater throughput of patients in the surgical division. On a positive note, and you're going to think I'm biased here because I'm medicine, but on a positive note, there are green lines within medicine and FSS around first outpatients as well. And overall, we are close to the 104% if you look at the total elective recovery line. And just to remind people, we're doing 111% of follow-up activity, which sounds like a lot when the expectation was to try to reduce follow-ups. However, we held the line that we would not try and reduce our follow-ups because of the backlog that we have, which I'll touch on a little bit later on as well. So that in terms of referral to treatment time, so on a really positive note, we don't have anybody now waiting over 104 weeks, and we've made improvements in over 78 weeks, which I'll go on to more detail, and also improvement in patients waiting over 52 weeks, which is great. We have a stretch target, which we are behind on, which I'll touch on in more detail. And then in relation to ASIs, again, in some specialties, we've made significant improvements in reducing the number of people waiting over 22 weeks for a new appointment. And again, I'll touch on the specific specialties in later slides. The holding list still does remain a real challenge for us, which I'll come to in more detail. So this really, sorry, the next slide, please. Next slide, please. So this slide really just shows what I've just described in terms of RTT progress, and that we're ahead of trajectory for 78 weeks, and for 52 weeks we're ahead of the national requirement on 52 weeks, which was to not have more patients waiting for 52 weeks at the end of this year compared to the end of last year. But we do have that stretch target, which is the grey line, which we're not quite tracking on, but are still challenging ourselves to get to. Next slide, please. This just shows over 78 weeks, which I've mentioned already. Next slide, thank you. So this shows by divisional breakdown. Surgery have made great strides in reducing their over 78 weeks, which is related to surgery for them. FSS have made some recent improvement as well. And again, this is linked primarily to gynae operating, which I've described the plan in terms of trying to increase that through September and beyond. And then in the medical division, the numbers are low, but this tends to be linked to neurology. And I'll just mention at this point, because it comes up in further slides, for neurology, it is probably our most challenged specialty in medicine. And that's driven by a lack of consultants primarily, and the difficulty in recruiting, which is a national issue. We have managed to secure some outsourcing though, and we've started some additional clinics around about a month ago, working on the weekends, and our plan is to get to a 52-week position, which is the same as it was at the back end of last year, which will be a real achievement given the volumes which you'll see that we have in neurology. Just going to the next slide again, please. Thank you. So where are we at now? Sorry. So ASIs. So I'm just catching up on my notes as well. So ASIs. So we were tracking against trajectory around ASIs, but we have seen an increase, and some of that is linked to increased demand in terms of referrals, but also challenges in running additional clinics. If we just go to the next slide, and it shows divisional breakdown. Thank you. As you can see, the main challenge and the high volumes is in the medical division. And if you go to the next slide again, you can see that our significant challenge really is in neurology, particularly in medicine. And that sharp drop that you can see in terms of ASIs and the improvement there is linked to the additional clinics that I mentioned. And we expect that to continue to pan out for the remainder of this year using that outsourcing. Cardiology is a challenge for us also, and this is in relation to our ability to secure additional in-house clinics, which we continue to work on. Next slide, please. Thank you. So our focus really with ASIs primarily is to clear the over 22-week waiters, and then we'll look to clear the other waiters on the ASI list. And as you can see, there has been significant improvement. And if we just go to the next slide again, that is shown again with that significant improvement in medicine, which is largely driven by the neurology additional capacity that I mentioned. Next slide again, please. And next slide again, please. So it takes us on to the follow-up backlog. So I mentioned in one of the earlier slides, this is a significant challenge for us because of the high volume of patients that we have. And we are focused on clearing the very longest waiters, but obviously there is a need to clear more broadly the volumes that we've got on the follow-up backlog. So the organisation, through a number of specialties, doing a lot of work on PIFU, and I've seen some information this week that just shows the impact that that is having. But clearly there is still a need for us to continue to see a high number of patients for follow-ups, and I would anticipate that that will go into next year as well. Next slide, please. And again, this shows the divisional breakdown. Sorry, just go back one slide again. Just shows the divisional breakdown where surgery's made some significant improvements. Medical division, again, a lot of this is linked to neurology because of the very high volumes that we have there. So again, we would expect to see a tracking down in line with the additional outsourcing that we've secured for neurology. And next slide, please. So it just takes us on to diagnostics. So overall, I'll come into a bit more detail around echo and neurophysiology, but there has been an improved position of around 10% for echo and 5% for neurophysiology, which is good. And sleep studies has also improved. And that, along with MRI improvement, has also given an overall improved position of 4.29% for the month, which is really positive. And then if we just go to the next slide, it takes us to the detail in terms of MRI. So what you can see in the chart is a trajectory that was put in place, or a plan that was put in place at the back end of July, and a number of actions were undertaken in order to increase the volume through MRIs, through the MRI. And that was linked to an additional scanner, a mobile provider, along with the staff that came with that provider. And essentially those 4 key points at the bottom of the slide are the key assumptions really that the plan was based on. The aim was to get down towards 0 6-week breaches by the end of August. There has been significant challenges through August, just with the acute demand that we've had through the organisation, and that acute demand has displaced some of the activity that was expected in August to be provided through the additional unit. But from speaking to Stephen Shepley, the DOP, they are achieving 90%, which is still an improvement, and they expect that improvement to continue in line with the actions that continue in terms of the additional capacity put in place. And next slide again, please. And then it just leaves then for the last slide around neurophysiology and diagnostics. You'll see there's a large spike in neurophysiology. So I've looked into the detail of this this week, and we're addressing this. So essentially, that spike was linked to some clinics. So a pause in clinics being opened. And unfortunately, we're reliant on a few people to open the clinics and book the patients in. And we had unexpected sickness within that team that significantly impacted. That has been addressed now this week with those clinics being opened up. So we'd expect that to drop back down to the place where it was. Neurophysiology is a challenge for us. Again, the challenge is linked to workforce and primarily consultant workforce. We have recruited 2 internal specialist registrars, though, that we're training up internally, and we expect that capacity to kick in the next couple of months and help us on an improved trajectory for neurophysiology. And then with Echo, there's lots of work being done in Echo in terms of workforce plans, and we have an internal training program for echophysiologists, and that has kicked in. We've recruited as well recently, and that's why that improvement is shown to be playing out. We are still heavily reliant on additional clinics, and the staff do work incredibly hard in that team, but we are on an improved trajectory, which is positive. So I'm conscious I've absolutely whizzed through that, so apologies for that, but there's so much content to get to, but happy to take any questions.
No, thank you, Johnny. I know it's a nice, clear way of getting the information across, though, and getting the sort of sense of where where the issues still lie. Just on a confidence point, in terms of the overall picture, what sort of your confidence levels do you think, with 10 being really confident and not being not confident at all, of turning any of those sort of reds to green on that first line?
Is that in relation to the 104% particularly?
Slide. Yeah.
In the summary slides. Yeah, I think there's definitely confidence that the trajectory will improve based on the actions that are in place. So there are significant challenges, or there has been significant challenges in getting the throughput through the theatres, in particular in relation to the ODP and the nursing staff challenges. I know from conversations with the surgical team, a lot of work has been done around recruitment. A lot of work's been done to ensure that people don't leave as well from the retention side of things. And that will definitely play out in September with that sharp increase in the number of lists. I think there are a number of challenges, though, that are ongoing. The payment and the rate card challenge is one of those, and the expectations from clinicians in terms of the amount that they will be paid, and how that plays out over the next few months could have a significant impact on the volume that we can do through not just theatres but clinics as well. But from speaking to the surgical team, they're certainly confident that on the recruitment and retention side of things in surgery, there's been significant improvements which will increase the throughput. It's just the other factors, I think, that are challenging.
Yeah, I just want to get a sense that we manages our expectations a little bit, that we're heading for all green across the board. Well, probably we're not, actually, and therefore it's about what we can reasonably expect to deliver against. So Tim, your hand went up and down. Did I cover your point?
Yes, you did. Thanks,
Sorry.
Helen. It was exactly that, the degree of confidence in getting to the activity for surgical. Thank you.
Yeah, okay, thank you. Brendan?
Well, perhaps I think we're all saying the same thing, and it could be argued this is semantics, but I think this speaks to the earlier debate, Helen. How do we turn our conversation from performance or KPIs or performance indicators to a level of confidence against delivery? There are variables that we're all dealing with, and I think that, as I called out, the uncertain certainty of industrial action in this country will have an impact on elective recovery, and I think it's a conversation we'll need to keep reviewing as a board. I think, Johnny, the confidence in our colleagues is there, but there will be issues beyond all of our controls, or indeed our leadership, that will test this out. I think looking at the position nationally, West Yorkshire as an ICS is probably lower down the league table for elective recovery, but within that, CHFT remains higher up. But we're not naive to think that we'll stay in that position, or indeed that this is going to be easy. I think your point about are we still going to aim for green throughout our trajectory is one we need to revisit, because I think that in some ways that's the old money conversation, isn't it?
It is, and I just think we need to maybe reset ourselves a little bit, because you don't really sit here thinking, we're still failing, when actually we may be doing as well as we can do in the circumstances we've got. It's just that mindset piece, I suppose, that natters me a little bit. Okay, if there's no further questions for Johnny on recovery, but again, please pass back to your colleagues all the work that they're people are working so hard. Nobody's coming in trying trying to sort of just swing it a bit, are they? You know, people are working so hard to do this. It's so important. There's people at the end of here, you know, that have been, you know, waiting for so long. And, you know, you've fantastic job on the 104 week waiters. You know, that's great, and good progress on all of the other waiting times. I know we deteriorate a little bit around the ISIs and our performance there, but you know, let's give credit where credit's due, and I know people working really hard to do that.
Thanks, I'll definitely pass that on. Thanks.
Okay, thank you. So month 4 financial summary, and Kirsty, I think she's still with us. She's still with us. Yeah.
Hello everyone, my name is Kirsty Archer. I'm Deputy Director of Finance. I'm here for Gary today. So conscious of the conversation earlier around the sheer number of KPIs and facts and figures in the reports, I'm going to pull out some key messages across really 3 core areas that we look at. So income and expenditure, capital and cash. So from an income and expenditure point of view, in the year to date, we are reporting a deficit of 8.44 million, which is slightly better than plan, but obviously still a deficit, with a favourable variance of 0.46 million against our plan. That's supported by the delivery of the efficiency programme, which is ahead of plan in the year to date. It's offset somewhat by operational pressures, so higher COVID numbers and greater bed capacity requirements than our original plans had assumed, and those plans were based on national guidance, and so that brings with it additional cost. There's been some recognition nationally of this pressured position, and the funding regime's been tweaked accordingly, with the elective recovery funding, which is contingent on that 104% of activity delivery compared to 2019-20. It's now been confirmed that in the first 6 months of the year, there'll be no financial clawback of that funding based on performance. So that sort of mitigates that risk for the first 6 months and allows us to assume that income comfortably in our position. One other thing that I'll pull out as a key metric is the agency expenditure position, and so it's obviously got a clear link to those operational capacity pressures as referenced, as well as the elective recovery ambition. This agency spend is higher than our plan, linked to those factors, and so in the last month, we have had our agency trajectory confirmed by the Integrated Care Board, and the trajectory that we're measured against is in line with our plan, which keeps things simple. But what we see is that in the year to date and in forecast terms, we are currently running above that level. So sort of to Brendan's point, really, in the moment we're managing, but looking ahead, the position is challenging, and we see that in the forecast terms. We have an overall forecast planned deficit position in line with our plan at 17.35 million. This is looking increasingly challenging, but the forecast at month 4 is to continue to achieve this plan. This assumes a number of things falling in line with plans. So it assumes the full delivery of the 20 million efficiency programme that we're working on. It assumes full receipt of the elective recovery funding as well. But obviously the first 6 months of that is now more secure than it otherwise would have been. There's obviously a range of risks and potential benefits, and they're highlighted within the paper. So I'll move then on to the cash position. So we, at the end of the month, had just over £52 million in the bank against a plan of 58.6 million, and that difference is due to just the timing of some payments on capital expenditure going out the door in the main. The good news is that that overall cash position remains healthy at this point in time compared with where we've been in years gone by. And finally, capital. We are below plan in the year to date with the amount that we've spent on capital items. So lower than planned spend on a range of areas, IT, equipment, leases and elements of reconfiguration. The forecast is to come back online with plan by year end, and people are being really encouraged to crack on with those investments. And I'll end on that note of cracking on.
Right, that's great. Thank you, Kirsty. I thought we've all inherited the Brendan Brown crack on narrative now. Karen.
Thank you, Kirsty. You'd answered my point on the agency spend, and I think that's something we need to keep a close eye on as we're going forward. As you say, it's only month 4. My question was around, obviously we all know, you know, it's all around us about energy costs. And, you know, we're heading now towards the winter months. How are you factoring in, you know, the increase in energy costs, and will that create even more pressure on a very tight budget?
So our original plans factored in a level of increase in energy costs, and that's obviously driving part of the deficit position. And then equally, some of those excess inflationary pressures were recognised nationally, and that's where you saw our plans move from a early iteration, which was a £20 million deficit, down to a 17.35 million deficit, recognising that additional funding that was awarded nationally. What we have seen during the course of the year is some additional unexpected pressure being now forecast, particularly with regard to the Calderdale site and the contracts that we've got there. So that's one of the elements that's challenging within our forecast, but it is already in our considerations. I think the greater challenge really falls into next year, because obviously the same with your energy at home, you have contracts which last a certain period of time, and where you see these real spikes is when you come to the end of contracts. And so it's next year where we're anticipating some further pressures. There is some work being done across WIAT, the West Yorkshire Association of Acute Trusts, to draw together an overview of where those peaks are expected to come across the whole patch in the energy bills as different people's contracts come to end at different points in time.
Okay, thank you. Good good understanding of how that's going to impact. That was helpful. Tim?
Yeah, thanks, Helen. Yeah, Kirsty, you mentioned a number of risks there to the forecast, and there's a few more mentioned in the report as well, you know, ranging from inflation, the PFI contract costs, the pharmacy manufacturing unit income, etc. It was just to say, I just think it could be really helpful to see a quantification of the risks to forecast, and maybe a quantification of any opportunities or mitigations that have been identified at any point in time as well. It would just help us kind of understand the quantum of the different challenges, and might just help us understand where are the areas that we need to focus corrective action on.
Yeah, we certainly have that behind the scenes, and so yeah, we can provide some more information on that, and we build that into sort of best, worst and likely case scenario planning.
Okay, that's great, thank you. The only other point was, it's probably a very stupid question, it was just around the PFI contract. Notice that there's an RPI mechanism attached to it. That's horrendous. Is there no kind of opportunity to renegotiate onto a more reasonable inflation basis?
Whilst ever we are within this contract, that is the situation that we're in. I've been here 14 years and nearly 15 years, and in every one of those years, bar one, that's been an increase. In one rare year we did see RPI go in the opposite direction, but obviously it's quite extreme at the moment. Again, that is something that we had anticipated at the planning stage, and so it's part of our overall deficit plan. What there isn't is any refinement or targeting of the way the funding is distributed nationally to take account of those with PFIs versus those without PFIs.
Okay. Okay. Thanks.
Okay, thank you. Nicola?
Thanks, Kirsty. That was really helpful. I was just wondering, I know we've already touched on the cost of agency spend, and I guess I was just really interested in that in particular because of the increased scrutiny we're seeing in HSJ and in the widestream media around that at the moment. There's a lot of stories circulating. I know we're working already with the ICS around this agenda, but how are we looking, benchmarking against our colleagues in other areas around this? Are we an outlier? Are we absolutely in line comparatively with our spend to other areas and our trajectory, I guess?
I think a couple of things. I think in some ways we are victims of our own success on this, in that if you go back a few years, at our peak, we spent over £23 million in a year on agency, and we had a lot of concerted effort then over a period of a number of years to extract ourselves from agencies, focus more on bank, obviously recruitment, retention, etc., etc. And so our agency trajectory, as I say, is set in line with our plan. Our plan is proportionately lower than others in the region, although there is quite a variability across different trusts. So we're sort of being held to account based on recent historic performance, as opposed to people being given a target based on turnover or any other sort of basis like that might be proportionate to scale.
Helen, I think, Nicola, we might pick some of this conversation up in some of the risk debates, because I think it speaks again to where are we benchmarking in this, and what level of confidence have colleagues got in us based on the trajectories that Kirsty's called out. I wonder if we could revisit your question in the risk element that we're picking up later. So I think we should it'd be interesting to see, well, Kirsty, it would be interesting if you could share where other organisations are, because I think there has been a shift across the piece.
Yeah, so we have a broader conversation at sort of after 12, don't we, around sort of our overall financial position and some of the risks and issues. I do think there's a sort of valid point to bring back in future reports, I guess, around the better understanding of risks and mitigations as raised by Tim. In particular, I think those that are ours and those that are everyone's. Because when they're everyone's risks, then often everybody's affected similarly. The benchmarks sort of don't overall change, and often there's national support for things comes in later. But when they're our risks, that's when we become an outline. I think that might be helpful for people to sort of understand better just in the overall report in the future. Okay, final question from Nigel, and then we'll have a little break.
Thanks, Kirsty. A couple of points, if I may. First one was more a comment than, and the second is probably a point of clarification. In terms of the ERF funding, it just follows on from the previous discussion, and also discussions about the IPR, etc. That my understanding is that the ERF funding risk has gone into the first half of the year. Second half of the year, as far as it stands at the moment, it will depend upon performance, but that's the performance of the whole of the system as opposed to just our individual performance as a trust. So again, that benchmarking information will be useful, well, both in the finance report and the IPR and the review of performance. I think in future, from a personal perspective, looking at the riskies, does everybody else hit the target as well, even if we do? The second one, the point was about the clarification on, you mentioned cash in there, and at the moment I think it's 56 million. Just if my reading of the chart that's in there that says even if we hit the plan, cash would stand at less than 20 million by year end. Is that correct?
That's correct, yeah. So we see it diminish across the year for a number of reasons. So obviously the deficit position eats into our cash. We've got a significant capital programme, and we entered the year with significant creditors from the prior year, particularly around capital again. So there's lots of things which eat into our capital across the year and see it our cash, which see it come down by year end. As you say, we still see it stand of the magnitude of £20 million this year, which is still a significantly healthier cash balance than we've been used to in years gone by, just pre-pandemic, when we were in receipt of borrowing and we were managing to a month-end cash balance every month of 1.9 million. So if we were to end the year with something of the scale of £20 million in the bank, I would remain pretty comfortable for this year. Where I would start to get concerned, and we're flagging this with the ICB, is as we go into next year, with that trajectory ongoing, our current forecast is that we would exhaust our cash next year, and so we would have to look to how that was managed either across the ICB or through revenue support routes which are open to us.
So that's a risk that might not necessarily be there in the current year, but for future years or for next year will be highlighted as part of next year's plan.
Yeah, indeed.
Okay, thanks.
Brendan?
It's a really brief point, Helen, but it speaks to the here and now and the future debate and the risk and level of confidence. I think F&P's next week. I think we're a bit out of kilter. It might be Andy's not here today. I'm conscious of that, but I do think we should have a conversation about committees of the board. We're out of kilter with some of our dialogue here, so I think we need to be bold in that.
Yeah, we've got very out of kilter with F&Ps. I think they're all sorts of odd days as well. So I think Vicky's on the case with that one, though. I think in terms of trying to get things back into a sequence. Okay, so we are going to have further discussion around some of our, particularly around our risks and the overall sort of consequence. In the meantime, if as a board we receive the note the report as it's presented today. And acknowledging that maybe in future we can highlight sort of some of those risks and mitigations that we're facing. Okay, I'm going to let you have a little comfort break now. We're on the staff survey action plan now, and is Jason taking us through this, or is it you, Susan?
Well, I'll do a quick intro, Helen, and as requested, we'll keep it really, really short. So this is last reviewed at board in May. The new staff survey launches in September, so 26th of September until 25th of November. Obviously, all trusts who complete the survey are going to have their own challenges. So in line with what you've just said, we'll have our own risk, but so will everyone else. So no excuses. Last time we did discuss the board, we focused on some high impact actions. We put on a plan on a page just to let board know there's a much bigger action plan that sits behind that, of course, that we monitor within WAD, within divisions, and also at Workforce Committee. But a couple of those high impact actions were visible leadership, one culture of care, leadership management development, celebrating achievements, health and wellbeing, and creating a sense of team. And I thought today's discussion could perhaps focus on how we as a board have contributed to those high impact actions, what we've done since we last spoke in May, or what we've observed, both good and what we think we could possibly improve. And I'll just leave it at that.
Okay, so there's a number of things I think that certainly I've been picking up as I've been talking to people around I guess where board members in particular have been trying to further those actions. I don't know if anybody wants to share anything specifically. Nobody dare say oh now because we don't know where we are on time. No? Oh yeah, Lindsay.
I'm happy to share some of the things I've been doing. I'm exec sponsor for the ED, so I regularly drop in. I tested out the checklist, which is hard to do if you've got it in front of you. You've got to learn to have the conversation and just use the questions off the checklist rather than kind of go with a tick box filling those out in terms of that and supporting staff at different times. So you don't always do all of it in one go. I tend to do it as I'm going through and dropping into different areas. I've reviewed their action plan and perhaps strengthened it and simplified it, and how they communicate some of that as a senior management team, and what is the role of the senior management team and how they're managing that. I've got regular meetings in with the CD and the GM. I've done listening events in theatres and maternity, so outside of some of the areas that I'm just the sponsor for in terms of other broader commitments around one culture of care. I tend to hand out the appreciation cards outside of the appreciation week. So if I'm going somewhere, I tend to fill one out and make sure that I have a conversation at that time. And then it...
You're frozen. Oh, I think you're frozen. You're back.
Clearly Brendan's been sorted out, but not me then. So it's me now. And then any time that I've just got 15 minutes or a break, you know, if you finish a meeting early or it cuts off halfway, I'll try and do a bit of a drop into somewhere, and particular ED, and then it's just focusing on having those compassionate conversations with people.
Thank you. And it's good to just try and bring it to sort of life a little bit. Karen?
Yeah, I mean, obviously from my perspective, it's part of the agenda for the Workforce Committee, but it's trying to make it more of an integration into the conversation as opposed to something that stands on its own, because it should be part of what you do rather than a standalone kind of item. And I think it's asking the committee more about, and the people who are presenting the papers, more about how this actually progresses or deals with that one culture of care. From a personal perspective, it's continuing with those visits and also the tea trolley rounds where you can actually get to people. So I'd like to see more activity around that from a personal perspective, to visit different areas, not just the areas that we have that are designated our leads, but generally across the piece, now that we perhaps can be much more visible. And as Lindsay said early on, it's really about trying to factor this into the conversation. And apologies for the dog. He is very caring, and factor that into the conversation, so you kind of get round to what you need to ask without being too overt about it.
Yeah, thank you. I think it's a really good point. Certainly I've been picking up in some of my sort of induction conversations about sort of making sure this doesn't become initiative-itis, but becomes natural and becomes a sort of just way of being, if you like, which then is difficult when you need to capture it in order to evidence it. Now, probably we'll come back to Jason sort of just in terms of just asking some questions around how we draw in the feedback from these things into be able to evidence some of this. Brendan?
Brief, Chair, just and Jason, you can take us forward on some of this, but I think it's the one culture of care on each agenda item. I think this is where we need to change our thinking, probably to Karen's point. We often do a review of meeting at the end of every meeting, don't we? What we should be testing ourselves out on is, has that meeting been delivered within our values and behaviours? Has it met all of the remit of one culture of care? And I'd argue for all parties in the meeting, not just for those leading it, because I think, as I said before, I think the position we're in could generate a set of behaviours in response to actions or demands, and actually it's how we should be using this to hold our nerve in how we conduct business in this organisation. So I think there's a nuance to it, Jason, that we could look at, rather than it being the blunt, instrument of one culture of care, we should test ourselves out about whether we've lived by our values.
Denise?
I just wanted to add briefly that certainly from a quality committee, unfortunately at our last meeting we, as invariably we do, ran out of time. But the kind of work that we've started certainly is to ask the authors of the report that are coming to committee to actually ensure that thought is given to how the report is able to support and is evidencing one culture of care. So that's certainly one thing, and I agree with the points that have been made about looking at one culture of care and for it not to become a tick box approach to how we address one culture of care, particularly in committee meetings. And on a personal level, I've been able to actually get out to a number of tea trolley events, and really that was really quite powerful in terms of information that's coming through from colleagues. I agree with Karen, we need to see, we need to do as many as possible of those that we can do. I recently also was able to join the first meeting of the Developing Inclusion Committee, and like other people have said, it was actually quite useful to ask the one culture of care questions, though, but not in a way that was particularly obvious, but was getting the responses that were answering the questions. So I think, Helen, in response to your question, it's developing, and for all of us, I think as we progress, we will come up with ways of making this we're doing this, and it becomes embedded without it actually being an add-on, as people have already said so far.
Yeah no, I think that's a good point, and I think I think that what becomes harder when it becomes a sort of, I guess, more sort of natural activities, it becomes harder to capture. So Jason.
Thanks, Helen. Hi, everybody. I'm Jason Edelson. I'm Deputy Director of Workforce and OD. I think it's a fair point, Brendan, you've flagged, and I know Denise and Karen are endorsing the point and promoting embedded activity within the committee structure that they lead. I think the agenda item is a point in time step. I think a test of whether we're truly embedding one culture of care will be to feel one culture of care conversations in every single meeting, every single conversation that we're having, whether formal or informal. And what I'd like to see, what Suzanne and I'd like to see over time, is the dropping of that agenda item, but still a focus on whether in meetings we are exhibiting one culture of care behaviours in the engagement with one another, and whether there is that thread that Karen mentioned in each paper, each item we discuss, that focuses on our people, yes, but behaviours of our people and how we engage our people and how we're seeking to improve the colleague experience overall, which ties us nicely back into improving our staff survey response and feedback in that response.
Yep, thank you. I've been reflecting myself on the meetings so far, and thinking, because I know we have an agenda item at the end, which we'll no doubt run out of time for. But just thinking in terms of the agenda so far, I felt that it really has permeated the discussions that we've had. And it can be easy to be cynical about things like this, but at the same time, I'm sort of getting more involved with the trust, I do get that real sense. It does feel quite palpable to me, and I can be the world's greatest cynic on these things, but I do think there is something. It's just like you said, trying to really sort of capture it, and then not need to capture it because it's so blooming obvious. I think that's the magic, isn't it, at the end? Okay. So I guess in terms of you know, some people have had better opportunities than others, I think, to engage in some of the board leadership activities, and it's maybe a reminder for those of us who haven't been able to do things like the tea trolley rounds and some of those broader conversations to get those organised. Oh, sorry, Karen, I'd not noticed you come back in.
Yeah, sorry, I just wanted to add in terms of the behaviours and the values and stuff. Well, that's very positive, but we need to make sure that we're calling out when it's not happening, when it's happening in a negative way, not when it's not happening at all, but when it's happening in a negative way. We need to be bold enough to do that. Sorry.
And have people been able to do that in discussions that they've had? Is that, you know, is there the environment within some of the meetings, the groups, the committees and things like that to be able to challenge if somebody's not really behaving like we would expect? A lot of you have had a lot more experience of this than I have in your meetings, etc. Tim?
Yeah, certainly. I think we've got an example in CHS where there was an issue raised, and then I think Lindsay showed some great leadership in terms of that being addressed. So yeah, it's the simple answer. I think we are raising issues.
That's good. That's good. And Johnny?
Yeah, I was just going to give the divisional perspective. I think it is really helpful. The one culture of care strapline is something that staff have grasped onto, and I've heard staff talk to me about other individuals that are not necessarily living out the values of the organisation and one culture of care, and it's helped them have direct conversations. It's helped me to support them in conversations. So yeah, I do think it's really powerful, actually.
Right. That's great. Thank you. And Tim, is your hand back up again? No. You're on mute now. You've gone. That's it. Jason?
No, sorry, I'd left it.
It's okay. Jason?
Thanks, Helen. I was involved in the design of the how-to guide for board members. So I've got a vested interest in seeing it used, but I did want to raise the fact that we probably do need to be better at documenting the activities associated with those commitments and how we translated those commitments into practical steps. And I'm thinking about co-quality commission inspection and how the board leads in the organisation and how that sets a tone for well led in the organisation. So I think there is a piece of work to do to better capture from individual board member colleagues that activity, and then demonstrate how that relates to the commitments, but probably more importantly, how that feeds into our staff survey planning year on year, or indeed, and probably more specifically, how it influences the design and content of our people strategy.
Okay, so on that point then, so we're asked to note today, but we're also asked to reflect on how we are progressing, and which, you know, we've had a very snapshot reflection, I think, of that. But I think building on your point you've just made there, if we can try and sort of capture this a little bit, and I don't know what methods you want to use to do that, whether it's just little quick surveys or whatever, or a little piece from each person, just so you've got a bit of evidence to sort of support it, and then at least you can sort of have something a little bit more tangible. So I'll leave that to you to consider outside of the meeting, about how you best want to do that. But I hope you've heard, even if it's just a flavour, that those commitments that we made back in May are being lived, and you know, are sort of coming through our governance arrangements as well as through our individual actions.
We'll get the brain trust together, Helen, and we'll design an approach, and we'll share that with board members, and watch this space.
Lovely. No, that's helpful. Thank you very much. And we've you've got a few little extra bits in the chat as well, so if you want to pick those up. So if we move on, if that's okay, we've now got just the update on the health and wellbeing update, which obviously is also part of our support to One Culture of Care, and this is certainly something that's come up in a lot of conversations I've had, particularly this way, wellbeing hour. Either they love it or they hate it, don't they? And some people think it's only for like COVID and not forever. So it would be good to get some of just a bit of a take about where we are with the health and well-being. That feels like well-being, doesn't it? Health and well-being work. So am I back to you, Suzanne?
Yeah, if that's okay. So we've obviously worked really hard on health and wellbeing. It's been absolutely vital over the last 3 years. We've set a really high bar for ourselves through the pandemic. We were involved in the initial work nationally with the Ministry of Defence on the Prepare, Active, Recover. That has guided us really through what colleagues will want. We've got 6,500 colleagues with 6,500 different individual needs for their health and wellbeing. But as Brendan's referenced in his presentation today, there's lots of things going on outside the workplace that are impacting on colleagues in the workplace. And of course, we do work in a service which is incredibly challenged at the moment. So health and wellbeing has to be the most important part of One Culture of Care and the most important part of our people strategy as we go forward. Our staff survey has seen tremendous increases in the responses from our colleagues in what they appreciate about the health and wellbeing offer we've got at CHFT. And in line with the comments on the Wellbeing Hour, Helen, we did have a health and wellbeing festival earlier in the year, and we promised that we would ask people what they thought about it, knowing that some do like it, and they're particularly those colleagues who get it, and there are other colleagues who just can't work out how to do it. So overwhelmingly, colleagues voted to keep the Wellbeing Hour, albeit we've made some changes which will allow more colleagues to take it and allow services to implement it more. So there's a couple of changes to it, which is it's an hour a week as it always was intended. In most situations that hour can't be carried over, and I'm just being very cautious when I say that, because some divisions may find that services have got a really good way of letting it happen, and it works for the colleagues, it works for the service, and we wouldn't want to get in the way of that. But we also do want to make it open and accessible to all, and that's for all staffing groups, and previously that has been difficult for in particular our doctors. So it's not contractual, it's not a promise, it's not about COVID. This is about making sure that we are putting health and wellbeing at the heart of everything that we do, and it's able to flex and be flexible around the individual's needs. I do think it is one of the things that colleagues tell us when they join the organisation they find different about us, and it usually goes hand in hand with One Culture of Care. So when colleagues join, they don't always have good comparators of what others are offering, and I think we should be tremendously proud of that, and the fact that we've stuck with it and that we've stuck with our health and wellbeing strategy as we go into the recovery phase, I think is for divisions to be applauded on, because they've really made sure, particularly in recent PRMs, that health and wellbeing is at the centre of their own people strategy. So this is a to note, but again, keeping it brief so that colleagues can ask questions, have conversations, share some stories or experiences that they've had with other colleagues. It will absolutely form the most vital part of our people strategy going forward, and probably will do so for now in eternity, regardless of sector, whichever sector people work in. So I'll open it up for questions, Helen, if anyone has any.
Okay. Karen?
Yeah, I take your point, Helen. Some people love it, some people hate it. But at the end of the day, I don't think we can't really not have this if we truly mean that we need a culture of care and we want a culture of care. It's one way of actually showing that we really do care, and we'll never please everybody anyway. But if we're pleasing the majority of people, I will be very happy with that, and I am very happy with that. I think what it's also done, the approach to wellbeing overall, has actually opened up the possibility for people to talk about how they feel and to actually access services. So it's not just about the wellbeing hour, it's about that freedom and openness to it's okay not to be okay. And sometimes people don't think it is, I need to be big and strong. The question I had was around financial well-being, because we always think about mental and physical well-being, but there's financial well-being now. Are we doing anything specifically to promote financial well-being? I know we do things on financial well-being. Are we doing anything specific to promote it?
Yeah, yes, we are. So we've got a fairly new organisation that's joined us. We've had a couple over the last couple of years, but certainly there are companies that we are using through our benefits team that people can access very low interest rate loans and can consolidate those. We've also got things that we haven't possibly promoted as well as we could do, which we will work on, like car salary sacrifice, etc. We also, in collaboration with finance colleagues, made sure that if colleagues are spending a regular amount on their fuel, for instance, that they don't have to wait to have that in arrears, that is with them if they work in our community or are this department, etc. So yes, there's a big financial well-being aspect of our health and well-being strategy. That tends not to be as promoted or as seen as other elements because people are very sensitive. I would say people are probably more sensitive about their financial well-being than they are their mental health well-being. So there's always more to do. We are looking at other things that we can do, especially in light of the fuel and energy increases. But we are doing a lot already on our financial support.
Okay, thank you.
That's great. Thank you. Denise?
This isn't a question, Suzanne. This is just very quickly some feedback. Recently, I've seen the effectiveness of a health and wellbeing champion in action in pharmacy, and the role for me, from what the colleagues were sharing, was really valued within the service. So I think really just to say that seems to be a really good initiative, and hopefully we've got health and wellbeing champions in most areas now. I'm not sure just how well we're doing with the spread right across services.
We've got about 125, I think, Denise. Actually, there's a lot of wellbeing ambassadors. They are not in every single area, but it is a group of people that are continuing to meet and continuing to learn from one another. Especially on social media, you do see a lot of the teams with what they've achieved through their wellbeing ambassador. So that's great feedback, and we'll make sure that everywhere has got one wherever possible.
That's great. So you obviously asked us to note the paper, but also our support for that we continue with our drive towards colleague health and wellbeing, which I think you are feeling, hopefully, from this group of people is something we really do support. I think like you say, we have moved into a very different era, I think, around sort of how we in the expectations there are of employers around staff, and it goes way beyond just paying them and giving them a job. It just goes way beyond that now, and we have to stay. It's competitive as well. It's a competitive marketplace, so it's good that we're out, seen as sort of a bit of a a reputation for this. That's a really positive thing. Okay, so if we're happy to continue to endorse the work that we're doing, and thank you to the team for continuing to think about this and trying to different sort of approaches, etc. I think that's great. I'm just going to pause just for a couple of seconds here, just for Gina and Stephen, conscious that we with the timing, but if there's anything so far from a governor's perspective around your observations or any points of clarification that you might like to make at this point on the agenda before we get into our sort of more routine reporting section.
I've no comments really, thanks Helen, but I would just make, one of our responsibilities is to make sure that our NEDs do check and ensure and challenge the board of directors, and I think they do an excellent job of doing that. Thank you.
Okay, thank you. We've got that on recording. Let's save that, Amber.
Yeah, it's a rare for me to compliment somebody.
Thank you. And Gina?
Thanks for the opportunity. It's been a great meeting. I have really enjoyed the vibe through it all has been really positive, and I can see how innovative you're all being. I love the phrase open and responsive culture. That for me has come across hugely in today's meeting. So I'm very grateful for that. And that's all I'm going to say, because I know times I could go on, but thank you. It's been a pleasure, because I'm only observing. I'm not officially here, but I have loved it. So thank you.
I know, but you know, you're a key part of the organisation, and I want to at least give you the opportunity to say, hang on a minute, if necessary. Okay, so let's move on with the rest of our agenda. We're into our keeping the base safe. Now, the first item, as I mentioned earlier, is the Freedom to Speak Up annual report. We just received that today, and we will have discussion. Please send in any comments you may have brought with you to Amber, and we will feed those into Andrea. And so we should be okay now to go straight to our DIPSI report, our Director of Infection Prevention and Control, Q1. If we could just maybe highlight any key issues for the board. This is a report most people are familiar with now, I think.
Yeah, thanks, Helen. I think it is self-explanatory, so I'll be really brief. Needless to say, COVID-19 is still presenting a major challenge for the IPC team, not just in terms of managing quite large numbers of patients through the Delta wave, up to 90 in the organisation, but also in regards to changing guidance, which they've had to respond to. You've had a number of ward-based outbreaks, as you would expect, and that happens in all organisations and largely reflects community transmission rates. I think the major issue of concern for us at this point in time relates to Clostridium difficile, where we're seeing higher rates than we've seen in previous years. This is not, again, unique to CHFT and may relate in part to increased morbidity amongst the population, increased use of antibiotics to manage respiratory tract infections, including COVID. We have an action plan in place to try and manage that, including review of antimicrobial prescribing, cleaning protocols within the organisation, the use of hydrogen peroxide vapor fogging, and a review of the mattresses that we're using to make sure that they're still intact. These are measures that we put in place in previous years, so hopefully they will start to have some impact moving forwards. I think finally, just to note, we've had a small number of outbreaks outside of COVID-19, a small cluster of cases of C. diff which were linked, and the vast majority are sporadic cases and not part of an obvious outbreak, but also a small number of cases of MRSA and Oscar-Boo. Again, those babies were colonised only. We managed that cluster without closing the unit and sought support and guidance from national teams. I think clearly, the quality improvement work, the audit work of the IPC team continues, and I think information is given in the report in relation to that. I'm happy to take any questions that colleagues may have.
Okay, thank you very much. Like I said, the report is both familiar but also fairly comprehensive. Has anybody got any questions for David or anything is said? No? Okay, so if people are content, we can both receive and approve this report. I approve the improvement bit, I presume, is because the N has to go to somewhere and it goes with our approval. Is that right? I'm still getting familiar with this.
So it has to be received by the board for approval, Helen. It doesn't go anywhere else, particularly from here. It's discussed in quality committee before it arrives generally.
Right, it doesn't get sent to any other people then. Okay.
Not at this point in time, though we do have to produce an annual report which is made public, and it will have the data that's contained within this.
Okay, so we approve the report as submitted. That's great. Okay, thank you. And I think we're still with you, David, as we move to the medical revalidation annual report. And it was great to read about the re-engagement, I think, post-COVID in this report. So if you would like to take us through this, and this is one that I think we do have to then approve for Brendan to sign it on our behalf. So there's quite an active approval process here.
So again, I'll try and be equally brief in relation to this paper again, because I think it is self-explanatory. There have been a number of challenges in relation to appraisal and revalidation of medical staff through the COVID pandemic. Indeed, the recommendations around revalidation were paused for over a year. There's been a modification of the appraisal process as well, but we are now back up and running, formally making recommendations to the GMC to revalidate colleagues, and we have our revised appraisal process now running in place, and those appraisals are mandatory. Performance is good within CHFT. We appraised around about 94% of all colleagues, around about 5%, or 5.3% were not required to complete an appraisal either because they were on long-term sickness absence, pregnant, or had just arrived within the organisation, which left us with 3 missed appraisals out of over 400 doctors, so less than 1%. So I think that, given the fact that we were re-establishing the appraisal process, I think was good performance through CHFT. In terms of revalidation, we made recommendations to revalidate 89 doctors through the last year. We have deferred 2 in relation to that recommendation. That's not a negative position. It just means that they need some more time to gather the data generally that they need to present so that we can make a positive recommendation. I think the paper gives you assurance around the processes that we have around appraisal and revalidation, which we need to formally sign off and return to NHSE, the GMC. So I think with that, again, I'm happy to take any questions that you may have.
Okay, thank you. Karen?
Yeah, thank you. And I'm assured about the process, David, because I think your completion rates have been excellent, actually, under the circumstances. They're still challenging times. My question, and maybe I've misread this wrong, and it was in the table, one of the tables, and I think it's page 100 in the bundle. It says there was a lack of engagement of 3 doctors. Maybe I've misread that, and correct me if I'm wrong, but what does that mean?
So those are the 3 doctors who had an unapproved missed appraisal. So we try and encourage strongly all those doctors to meet for their appraisal. Those 3 doctors there are those that didn't engage with us through this year.
So it doesn't impact on their revalidation. It's not linked.
It may if it's repeated.
Right.
So the GMC, the GMC expect people to have a regular appraisal. There's usually some give and take in that. But clearly, if they haven't done an appraisal for 5 years, then we'll be having a conversation with the GMC, and they probably won't get a positive recommendation to revalidate. If they've missed 1 appraisal out of 5 years, then GMC are usually comfortable to allow that to progress to a positive recommendation.
And is their job plan set through their appraisal? Sorry, that's just for my...
The job planning process is separate to their appraisal process.
Okay, that's fine. Thank you.
So I guess on that point, at this point, there's nothing to concern us about those 3. It's just, it'd be concerning if it's here next year and it's same 3.
Yeah, I mean, there are obviously some colleagues who present us more challenges than others in terms of appraisal. But we generally get there.
Yeah. Okay. So if there's no further questions, are we content that we approve this report for Brendan's signature on our behalf? That's great. Thank you very much. Keep ahead on my paper there. Okie doke. So, and I think we're still with David. You're getting a bit of a run here, and it's all right because then Lindsay gets a run. Again, we're moved on to David. Learning from Death's Q1 report. Again, a little bit like the Dipsy report. We get the quarterly one and then the annual one. And if you could possibly, when you're just reporting on this, just explain this lag issue. I have had it explained to me because I didn't quite get it, but it might be helpful for the board members to understand this lag issue and how it's going to be addressed in future reports.
So the lag issue relates to the time after the patient death when the review is done. So those are issued generally a month or 2 after the death. So the fact there will still be initial reviews taking place at this point in time in relation to the first quarter. So the number that you see in this report of 73 will not be a final number for Q1. I think what we're going to try and do is probably report a quarter in arrears so that you have final data when it's received at board moving forwards. That's the lag issue. But at the time of writing of the report, we'd reviewed 73 deaths overall. We have a target of 50, but I don't think we should get too bogged down in targets and numbers actually in relation to this, because the learning, I think, from this is far more important, and we try to focus a little bit more on that in this report to sort of highlight, you know, what themes are coming through from the learning from deaths reviews to translate into our quality improvement program. And I think the paper does give you some information around that, particularly around managing people under the Mental Capacity Act and learning disabilities, end of life care, deteriorating patients, to name a number of areas which have been identified. It's a two-stage process, I think, as everybody knows. We have an initial screening review and then a structured judgment review. And just to remind people, this is a quality of care review. Issues identified in that do not necessarily mean the patient died of those issues. It's a quality of care review only. But nonetheless, we do identify poor care within those initial screening reviews. Those are sent on for a more structured review by trained colleagues. Medical examiner can also refer cases into that for a structured judgment review. And we also take alerts coming through SHIMI or HSMR into that process as well to ensure there's no learning for the organisation within those. So, you know, I think the report gives you I think a good idea of the progress that's being made in terms of these. I think it's showing that the learning from it is translating into the Trust QI programme. And again, I'm happy to take any questions that colleagues may have in relation to this.
Okay, so I suppose that was the only little bit actually from me, was about sort of when there is the poor practice identified, sort of where it goes and how it goes. But you cover that a little bit, but it's probably, I'd be interested in understanding that probably outside of here, but
okay,
how that works. Because we get lots of things that talk about, oh, we'll learn from it, but we don't always. It's become a bit of a catch-all sort of statement. So I would be interested, and it may be something the quality committee look at in greater depth anyway. So it may be a conversation I have there.
I mean, just very briefly, if there's very significant care issues identified, then they generally go through the SI process, and they may well have been referred to the SI process already. And we often quite find those things happen in parallel. But yeah, I can go into more detail with you outside of the meeting if you prefer.
Any questions from anybody else? Again, I'm conscious many of you are very familiar with this report and sort of how it comes through. No? Okay. Well, if we're content, we can note this report. That's all we're asked to do with it at this stage. And if we probably just make a note in the if we just make a note in the minutes around sort of maybe just some follow-up, just part of my own, I guess, interest in terms of how we take that learning forward. Then I don't forget to do it. Okay. All right. So I think we now move on. So thank you very much, David. And thank you for those items. And I'm sorry we've got you down to a few minutes. We now move into the Lindsay Rudge show. Now we've got two reports here, and I do know you had two presentations, Lindsay, I think, and I wondered if you don't mind just giving us maybe the headlines from the safeguarding report, but then focusing the most of your time on the quality report. Is that okay? And then we cover more breadth.
Yeah, that's absolutely fine. Thank you, Chair. So colleagues will have had the report and the presentation slides that go with that to pull out that. I think just a couple of headlines really. We've maintained compliance with our requirements around prevent, but just to note that our colleague BAME network have raised concerns about the content of the prevent programme in terms of that. So we're working with the Department of Health and Social Care around those concerns, and there's some meetings planned going forward to let them influence that at a national level. So an important piece of work, and that they felt able to flag against that training. In terms of safeguarding and COVID-19, we've continued to maintain all our requirements of working in partnership with the safeguarding arrangements at both places. We are starting to see an increase in complex mental health patients, and those are on the increase, as well as people with substance misuse, and that's in adults and children's. So we continue to review that in line with partners and monitor that. In terms of hidden harm, again, we're continuing to see an increase now in complexity related to harm taking place behind closed doors during the pandemic, where children were being at school and some adults who were vulnerable. So we again continuing to work on that agenda at place level. The Liberty Protection Safeguarding has been deferred, so we've no date for that going live. So we continue to work towards that going live, but there's no date yet at the moment. Training has been a challenge in maintaining some of our levels, but we are going back to a blended approach of the more face-to-face. Success story around our was not brought policy, so people that might not attend appointments for various different reasons, whether that's about a health inequality or being a vulnerable adult, and that's been noted as an area of good practice. But in terms of safeguarding adults, discharge remains a key focus for us in terms of some of the quality of our discharge, either into transfers of care or back home. And we continue to work with the South West Yorkshire Partnership Trust around the Mental Health Act, and all our service level agreements have been updated and agreed through that. And again, just in terms of maternity, we're seeing increases in mental health issues, and so there's a weekly specialist midwifery panel in place to make sure that we have got good governance in terms of that. So just to acknowledge, I think in the annual report that the safeguarding team have maintained significant activity throughout the pandemic and supported teams in different ways. So just wanted to acknowledge that.
Thank you. So this is absolute acronym city, isn't it? Is safeguarding with MACs and DRAMs and IDFAs and goodness knows what. You know, and I've been involved in this world for a while, and I still can't always remember what they are. And the other thing, and I did speak to this outside the meeting, this is I'm working on the assumption that are the same arrangements in place in both Calderdale and Kirklees, and that when there's an emphasis on one, it's just it's sometimes it may be drafting, and sometimes it's just because they're called different things. So there's nothing different, is there, between the two places?
No, there isn't. So we represent, obviously, in the boards for adults, and the health representative is from what would have been the CCG, is the ICB Chief Nurse for Health in the children's arrangements. But all the subcommittees, even though there might be a bit of difference at Calderdale and Kirklees, we're in all the subcommittees as you would expect us to be.
Yeah, thank you. Karen?
Yeah, just a quick comment from me. My concern was obviously also around the training element, because there was some reds in that, but you've assured me that you're onto it anyway, Lindsay, which is good.
Yes, we are. We've got a different approach now, which will hopefully rectify that. And supervision in adults is something new that we've put in, so I wouldn't expect it yet to have got to a level where it's increased. So yeah.
And can I just, so the system as a place, they will produce annual reports on safeguarding. Does our information just join theirs and it becomes part of the overall place reports?
It does, except for children looked after, which is a separate report because of the corporate parent that's required around that in local authority. Yeah.
Okay, thank you. And Denise?
Hi, Lindsay. I just had a concern that the case study 1, which shows really good working and across with other agencies from our colleague. My concern from that, however, was how much pressure does sometimes the approach that's used in CAMS, because from that case study, we were having to re-refer to CAMS to get the support that this youngster needed. I'm just wondering how much pressure on our capacity do we get from actually sometimes the lack of support from the CAMS service?
So it's an ongoing challenge. They've changed some of their arrangements, but I think where I reference that growth in children presenting into services, it's a national issue, Denise, around the level of services available to support that. So whilst we do it on a case-by-case basis, we are working with the lead for children's and young people from NHSE at a regional level, and I met with them this week about what we do as an acute provider in terms of managing through that, because it's not going to go away, isn't that presentation? So we need to work differently as an acute trust as well around what support, skills and training that our workforce has in enabling.
Okay. Yeah.
And that partnership MDT space that they need to do.
And can I just very quickly ask you, at the end of the report, absolutely correct, there's a statement about safeguarding is everyone's responsibility, and I'm just wondering, how are we doing to get that message out there and across?
I think we do very well, Denise, in terms of people raising safeguarding issues and safeguarding concerns. I think there's been so much more emphasis over the years on the importance of safeguarding. There's always room for improvement, but I would say we do very well.
Okay, thank you. So, a comprehensive report, and thanks. We know that as a board, but also thanks to the team for a challenging operating environment that I think they've been working in over the last over those 12 months that the report covers, and we ought to acknowledge that as well. Okay, so are we okay to move on to the quality report then? And again, if you can sort of, I know you have some slides here, so if you just want to sort of take us through the sort of things that that have been keeping the quality committee worried at night.
Okay, thank you. So the report covers the progress and position against the trust 3 quality priorities, which are around sepsis, hospital-acquired infections and the waiting times in ED. Myself and the medical director have met with 2 of the 3 groups and their leadership teams that are leading those during this reporting period, just to track that we would be on progress to achieve those targets at year end. I think there's certainly a challenge, particularly around what David's just described in the DIPSI report around the infection prevention and control, and given that we predict to have further waves of COVID, I think that one's going to be a particular challenge for us. There's some really progressive work being undertaken around sepsis, and we were assured that with some of the actions, providing they can get the actions implemented over the next quarters, that they would be able to achieve the majority of that quality priority. And obviously we've got the ongoing challenge around ED and the number of attendances and the operational OPAL status that we've been in over the last few weeks. So that obviously does remain a challenge for us. And I think when we come on to the IPR, you'll see a number of metrics that are of concern. There's an overview of the focus quality priorities, and again varied performance across those, and that's demonstrated in the outcome measures that are contained in the IPR. So falls and pressure ulcers, some of the clinical prioritisation around deferred care pathways, and our complaints performance is not where we would want that to be. So we've put some mitigations in terms of the complaints performance with a greater scrutiny on that, and a greater scrutiny through the weekly executive board around complaints. In terms of our activity with the Care Quality Commission, we've continued to have relationship meetings. The last one was maternity, and that was positive in terms of the feedback. But we're currently reviewing all our actions from 2018 to see if we're still in the same place around the things that we were asked as must-dos and what we should do. So we're due to complete that piece of work this week and then progress that through the CQC and compliance group and then through the quality committee, so that we've got a real position against where we were in 2018, so that we can be assured that we've undertaken and embedded all those actions. And we're on with the CQC roadmap as well. So we've got a real focus on children's services at the moment and urgent and emergency care across the acute floors, and then a number of the cross-cutting themes that were in the CQC roadmap, which was previously shared with the board. In terms of patient experience, we are continuing with the work around carers, and that's really positive, working in partnership with the council and the Voluntary Sector Infrastructure Alliance. There's some focus around end-of-life care that continues on the back of the national audit that we undertook, and we're repeating the national audit. The surgical division have come up with a much shorter audit tool to try to do some more real-life live experience around end-of-life as a routine ask when matrons are in their ward areas. And if that's successful, we'll roll that out across the organisation. We are looking at integrating the GERT process around legal claims and inquests in terms of what the national guidance was issued around that. So our head of legal is progressing that work with the clinical divisions. And then in terms of incidents and lessons learnt, we have had 2 further never events in the reporting period. So as an organisation, that takes 4 never events. 2 of them are historical. One was in July 17 and one was in June 19, but the others are in this financial year, one being in May and one being in February. So as a result of that, the medical director and myself have met with the surgical division to go through those, making sure that lessons have been learned and pulled through and any immediate actions have been undertaken. 1 investigation is complete, 2 are due to be completed by the 31st, the end of September, and the 4th one will be due at the end of October. So in terms of assurance, the SI panel has got oversight of those reports being completed. I'm happy to take any questions.
Okay, any questions from anyone or additions? So can I just ask about the sort of, I guess it's just sort of trying to get a sense of trajectory around the end of life priority area, and when you would expect to see that sort of pick up, I suppose. You know, I don't know what turns it to, as you can see, the sort of what we aim to achieve. Is that what good looks like? Does that tip it into being, you know, being an area that we can definitely say that we will progress?
So we've reviewed that, and Nicola might want to come in here in terms of we've strengthened the leadership into that particular work stream. So the Associate Director for Quality and Safety is now in the meeting and helping to support that work stream to progress those actions. And I know, Nicola, you've been involved in those conversations through the patient experience and caring group. So we should expect those to start to improve to amber for the next board report.
Yes, I had a similar question around the clinical prioritisation work, but that was more about the consequences of that being read. That sort of felt different to me reading it in terms of, so what does that actually mean from a consequences point of view?
So David, this one's yours, isn't it, in terms of the clinical prioritisation? Do you want to come in on that?
Well, I suppose ultimately, Helen, the risk is that we have patients there who in the wrong priority and therefore not getting the care in the timely manner that they deserve. I mean, I think we need to recognise that, you know, we've got even within the priority groups, we have patients who are delayed, and there's a risk of harm in those groups. So, in terms of the validation piece and the prioritisation around that, is to make sure, as far as we are able, that people are appropriately prioritised and taken forward for an early intervention should that be needed. So, I think the risk in terms of not being fully up to date with that is that we have unknown risk in that group.
I guess when I look across the whole meeting and look at across the whole reports and in the recovery piece, we're busy sort of, you know, saying we're doing really well on this and we're doing, but actually if we're doing really well with the wrong set of people, that's not really well, is it? And it's just sort of understanding, I guess, the impact of getting this wrong. And how we will and the work we're doing behind the scenes to improve upon it, accepting that, you know, this is from my understanding and my past experience, this isn't unusual.
Yeah, I think there's a balance, isn't there, between giving people time to actually see patients and manage their condition versus actually doing a validation piece. So we're trying to find a balance between, you know, what we have in terms of limited capacity and how we best use that.
Yeah. Okay, thank you. Tim?
Yeah, it's just a general question, please, just around the lessons learned. So we've got obviously quite rightly lessons learned from incidents, from complaints, from freedom to speak up, etc., etc. How do we trap all of these lessons learned and kind of cross-fertilize, if you like? How do we make sure that all of that information is accessible to the right people so that we can embed that?
I think that's a really important question, Tim, and I think there's further work to do on how we triangulate that information, whether it's in the IPR, whether it's in the softer narrative that you see through the quality priorities, as you said, freedom to speak up, what we hear from the listening events in terms of how all that comes together. And in some regard, we've tried to do that through the quality and performance report in that narrative, but I think we can do further work around that and improve how we do triangulate that, and we have been having discussions around how we could do that better.
Okay, thank you. So for this report we note it, but that takes us really nicely into the integrated performance report, and some of our right early discussions at the start of this meeting around sort of how enormous it is and being able to see the wood from the trees. But I think what that also demonstrates, that conversation, is the integratedness or not of it. So we've had a workforce report, we've had a finance report, we've had a recovery report, we've had a lot of the pieces that are then within the integrated performance report, minus maybe the workforce and other things, but also the story, I think. And I think that's what sort of Tim alludes to there, is the story of when you add all this together, what is it saying, which is sort of what the integrated performance report should be about. So I guess bearing in mind that we have covered a bit of this, but not everything, I did ask if ahead of the meeting if you and David would sort of, I guess, take this opportunity to try and draw some of this stuff together in terms of those, you know, how we're going to shift that dial on a overall deteriorating performance that we can see on that sort of front of the report, and what we really want to focus in on. So I don't know which one of you is going first.
So I'll start. Helen, I don't know whether I'll be able to achieve that ambition that you've set me, but I suppose it does tell a story, though, doesn't it? We've spoken a lot about the pressures that we've all been facing in terms of recovery, etc., and the pressures on staff as well. And some of those, I think, are translating through into what you see on this IPR, which is unfortunately a steady deterioration from April through to July. I think through that time period, we've been continually on a high Opal 3 heading into Opal 4, very high admissions into A&E and a very high bed occupancy rate. And indeed, with additional capacity open, and all that presents challenges to the staff who are already tired through COVID, and we may be starting to see some of those issues here. So, in relation to what's changed, I suppose the Never events, I think Liz has already spoken about those. These are not all been happening in the last 5 months. Some of them are historical, but nonetheless, that has deteriorated our position in relation to SAFE. But we do have action plans in place around those. I think what we're seeing though is, the challenges in ED in terms of high numbers of patients coming through, more than we've probably ever seen in the past, and that includes in previous winters, and that's likely to continue, if not get worse. So that in and of itself presents a challenge, both in terms of the safety of the patients, because we know that if you have long waits in A&E, that has a direct impact on the outcomes for patients later on in their journey. I think that was shown in terms of some of the work that was done early on around Shimmy HSMR. So I think that is an ongoing challenge for us. We have had some real challenges in relation to the discharge of patients, particularly to social care, because of the pressures that remain there. We've been doing a lot of targeted work over the last few weeks to try and improve that, and we have. So we are better at discharges now, perhaps, than we have been in the last months. And I think that is starting to feed through a little bit on some of the pressures that we're seeing in the organisation reducing. That, along with a reduction in the number of COVID patients as well. We've moved from having 90 patients with COVID into less than 30 as we speak today. So I think that may be helping. But there are still some real challenges for services, and I particularly wanted just to highlight stroke, where they're missing a number of metrics which were previously being met. And again, that's because we're seeing a high number of stroke patients presenting to CHFT, and we're having to respond to that. So we have a number of actions in place to try and manage that, but you can't turn these things around overnight and create additional capacity. So I think it is how we manage those patients better through their journey within CHFT and make better use of the facilities and community for their ongoing rehabilitation. I probably wouldn't, I'm going to mention Shimmy HSMR because they, remain concerns for us as an organisation. So Shimmy, fortunately, has now seemed to stabilise in the expected range. It's not where we would want it to be because we've been previously in the best quartile, but nonetheless, it has stabilised. The concern in particular for this meeting is HSMR, which has increased over the last year, again from a best quartile position to not formally outlying at this point, but heading in that direction. We think we know some of the reasons for that, and some of it's around palliative care coding. We've spoken about end of life care already, but nonetheless, we need to keep a focus on that. The quality improvement program that we have, including the deteriorating patient program, will hopefully start to bring some of those quality improvement activities together, and we hopefully will start to see an impact on that. I think it's fair to say that there have been higher numbers of deaths, not just within CHFT, but across the NHS. And it may be that these metrics are rebased at some point, which might improve our position. But nonetheless, we're giving a lot of focus to that. Having spoken about some of the negatives there are some positives in this report as well. And I think we just need to bear in mind that we've seen a significant improvement in our fracture neck and femur performance. Just as one example, I know we've still got some real challenges around dementia screening, but again, and Lindsay could be able to talk in probably more detail than I, we are pulling together plans to revise how we do that, which will hopefully see some long-term improvements in that, along with the use of whiteboards and other revisions to the admission documentation, which will hopefully support that moving forwards. Our cancer performance largely remains very positive and some of the best in the region, if not in the UK. And that's despite, a lot of support being given to other providers within Wyatt, in particular Mid Yorks, but also into Bradford at Airedale as well. So there are many positives in here, and the staff that we have are still going above and beyond to deliver high quality care for our patients, and we shouldn't lose sight of that in this report. Lindsay, I don't know whether you want to add anything to that. I haven't spoken about workforce or finance or performance, because I think all of those have been addressed in previous reports. But if obviously the exec colleagues want to come in and add anything to that, then I'd invite them in now to do so.
I guess the only thing I would want to add in, just to assure the board, is that we are going to review this in some significant detail in the Quality Weekly Executive Board at the end of September, to have a real focus on the quality metrics that we can see in all of these reports, in the previous one and in the IPR, to review what our response is, and if you like, do that further triangulation and understand what is going to be a priority for us as a result of that meeting. So similar to a quality summit, if you like, if that's a language that people would understand.
I think what's sort of helpful, I think a test for me, as you come out of here and you say, oh, you know, we've had a full morning in the board, and then somebody says, so how are you doing? And it's just a bit to be able to say, oh, we're doing really well on these things. We've got a lot of risks on these things. We're struggling with these things. We've got plan, you know, just so there's like a bit of a collective narrative, you know, exec and non-exec alike, I think, so that we've got that consistent, we all walked out of here with the same sort of information about how are we doing. And we can speak with confidence. And I think it talks to the earlier point about getting lost sometimes in the information and the data. But I think, you know, that summary I think was helpful in terms of like, yeah, we're doing better on discharges than we were. Actually, we're doing really well on cancer. And just knowing those, I know it's a bit soundbitey, but for us, I think, and all of you in those sort of system conversations, partner conversations, whatever, having that soundbite and that consistency, I think, is really, really important. And then it keeps us sort of focused on the measures that really matter, I suppose, for us. So any questions, bearing in mind we're sort of drawing it together around our overall performance here, and a lot of that you've picked up on already. Peter?
Thanks, Helen. Just a quick point, and it sort of plays to what you've said, actually, Helen. But when you look at the wagon wheels, if I can call them that, for those that are old enough to remember wagon wheels, where you've got a softening in performance. But what the report doesn't do is look at sort of more broadly at the external environment. It doesn't look at benchmarking against other organisations. It doesn't look at or cover all of the challenges that we're currently facing and other trusts are facing, the economic environment. And so if you almost got to a position of a weighted report, you might conclude that actually, for its moments in time, it's actually a good performance, but it just doesn't look that way because of the way it comes out in the report. So maybe it comes back to the strategy conversation about what we look at and what we don't look at. And I'm not trying to turn a report to make it look better than it is, but I do think there's something around the external environment and context which is missing and could make the report sit more comfortably in terms of where we are at the moment.
We want honest reporting, don't we?
And I think we've started to have that conversation, but I saw Brendan had got his hand up, so it's probably going to. That's one of the discussions we've had.
I think, Peter, look, the wagon wheels are going to go. I'm going to be really blunt because I think they don't tell the proper story. I struggled with them when we had them before, but I think the world we're living in is different. The challenge we've set the senior leadership team in the organisation is, are we acclimatising to this level of performance? And are we really drilling down to, I think, to your point, Peter, to understand, is this good performance in the context we're operating in or poor performance? And either way, we should be challenging ourselves. So it's not about massaging the metrics or the KPIs to get a better story. It's, are they fit for purpose at this point? But the wagon wheels need to go, in my limited opinion.
Okay, thank you. Nigel?
Yeah, thanks. Without going over that discussion again, Helen, the only thing I'd add probably to what would help me into that narrative is probably the actions. What are we doing about, this is our position. This is how it compares with others. What are we doing to improve, and what actions are we planning so that we can continue that narrative? Not only are we good at the moment, but we're planning to improve by, or whatever. It's adding to that narrative, and I can probably pick it out of individual reports on the agenda, but it'd be quite useful to have it all in one place to bring it together.
Yeah. Thank you. Any other further comments on the integrated performance report? So again, I think we're invited to note it, but I do think I think it would be good to try and sort of capture in our minutes that you know, we are wanting this to be a live discussion around how we improve on how we provide and present this information, how we triangulate it, how we make judgments based on it. And I think the final point from Nigel around and what do we do, you know, this is how we're doing, these are the things that matter to us, and this is what we're doing to improve, I think is important, and having that in a sort of more snapshot sort of way I think will be helpful. Again, no, without wanting to shove everything into the October development session, it, you know, much of that is a sort of it will not be fixed then, but we'll get our heads around what we would really like to see, I think, there. Okay, so thank you very much for that. We now I'm sorry, we're now way over time. So in extra time, we've got our sort of governance standing items. So I'm reliant on them helping me to catch back up again. Well, not that we can, because we're over, but off we go with our risk appetite statement, I think, is the next thing from Andrea, and then a conversation around risk more generally.
Thank you, Helen. This is a very quick one. Each year we review our trust risk appetite, which takes into account the current context within which we're working. That's presented in the paper. There are two minor changes to the wording, which are highlighted in red in the paper. So no major changes to the risk appetite. And we've just described in the paper the process that we use to identify any sort of breaches of our risk appetite to the board, just so that there's clarity for everybody on that. So I'll leave it there at that point. Any questions from anyone on that? Tim?
Just one query, please, Andrea. It was just on reputation, where I wouldn't have thought that our risk appetite was particularly high, or should be particularly high. I guess it depends what you mean by reputation with who, but you know, if you think about multiple stakeholders and especially patients in the local community, you know, I think it's very important that they have confidence in what we do. So I just wanted to query that, whether our risk appetite for reputation should be high or should be more like moderate.
I think the background to this stems from some of our history, really, in terms of the reconfiguration, and when we did have some difficult times with that, with our local views being different to the trust, and we marked it as high because to reflect the fact that we would continue to pursue what we thought was right, even though others might have a slightly different view of that. We would continue to do what we thought would be right for the trust. I mean, that discussion has moved along now, but that's the sort of thinking behind it. So we would make difficult decisions if we needed to, if we absolutely felt it was the right thing, not that we were looking to have a risky reputation with our stakeholders.
I wonder if it needs nuancing a little bit more, because it's much broader, isn't it, than just making difficult decisions based on a balance of issues. It's, you know, about not making reckless decisions. It's about, you know, how we present ourselves to the public. But at the end of the day, we're here to serve people, and our reputation is really critical in that role. We want them to have confidence in us, and that is born out of having a good reputation. So maybe that narrative needs nuancing a little bit, perhaps.
Okay, yeah, we'll take a look at the wording to see if we can sort of reflect that a bit more in the wording. Thanks, Tim.
Thanks.
Nigel?
I think you just covered what I was going to say. It's the nuance, and it's the, for example, commercial risk. If the risk is high but the reward is not particularly high, then we might not have a great risk appetite for that. So it's just down to how we reflect that, I think, in the documentation.
Okay, noted. Thanks, Nigel.
And Denise?
Yeah, I'm coming with yet another wording, Andrea. I'm looking at commercial and you've put in there consider. I'm just wondering, for me, because consider, it comes across as quite passive, really, in my opinion. And I'm wondering if we should be using something else like explore, where actually I'm assuming that we're being quite proactive and looking for commercial opportunities. So that's just a little thought from me.
Thanks, Denise. I think because Gary's not here, and I think he will have had quite an influence in that wording. That I'll pick that up with Gary, reflecting that conversation, if that's okay, and come back on that.
Yeah, that's fine.
Thanks.
I just wonder, Andrea, and so obviously I think, you know, it's like, oh yeah, this is just a quickie. I think there's something symbolic around the language here. And maybe when we get into our discussions around our strategy and our vision, maybe there's something about actually taking this into that context and thinking about that in a broader way, so that, you know, it reflects who we are and who we want to be. So I just wonder, rather than say, right, we'll sign this off today, that we take it into some of those conversations about our, you know, our direction and our vision and our aims and our ambition, and actually we reflect what that says in our risk appetite. Or is there something we have to do to have to approve it today, or can we just defer approval until we sit it in a broader context, perhaps?
Yeah, I think that makes sense with the refresh of the strategy, because this is very much linked to our strategic objectives, isn't it? Reporting through the board assurance framework. So yeah, let's take it there, and then hopefully we can reflect any changes then in the November report to the board through the board assurance framework discussion.
People happy with that approach? Yeah, I'm getting a few nods, so that's good. Okay, thank you. Sorry, Anna. Just spotted your hand there.
I was just going to say where we've got to about looking at it in more detail. I was just going to reflect. I think the original risk appetite was born out of specific trust board workshops to talk about that were in the context of that time around our external environment. And it probably is, as we've agreed, timely to revisit that, because the external environment has changed. The integrated working and partnership arrangements have changed, and membership of the board has changed. So it feels that it's a really good time to align that and around, you know, what kind of risk appetite is going to be key to enabling delivery of our refresh strategy, whilst holding true to our constitution and public duty and service. Okay, thank you. So if we can
Thanks,
note
Anna.
that this will come back in the future once we've done that work. Okay, so moving on, if we're okay to do so, to the high level risk report. Now you should have had a note round from Vicky, just in terms of if you had spotted in these reports, sort of, it's quite a bit of a change. There's quite a lot of work going on here around governance and management of risks, and so which we hadn't quite probably got across in the front sheet at the time. So within that context, I guess it's just, I always think at this point, if there's nothing we haven't already discussed, we haven't got as risk register right. But is there anything you need to further highlight in here, Lindsay? I think it is, isn't it?
No, I think if people have noted the increase in risks and that we're continuing to work through that process of how risks are validated, then we should have a more updated position in October. And Vicky and I are going to have oversight of that going forward. But I'm happy to take any questions about the additional risks that you can see on the register.
Okay, Tim?
Sorry, rather than a question about specific risks, it was just I wasn't clear what the mitigations are against each of these. Is that done separately, or should that be part of this report? You know, here's the risks and the next steps are these actions to mitigate.
And some of that detail is in the risk register that's appendixed in terms of those controls and how we reduce those risks, so gaps in controls and existing controls that mitigate those risks. But it needs to be clearer in the summary, Tim, that you see, and that will be part of what we conclude.
Okay, great, thanks.
Yes, I think the controls and assurances and gaps and things are all set out in the high level risk report, aren't they? Yeah.
Yeah.
Yeah. Okay, any other further comments? So we're asked to approve this, and I guess we approve it as it stands at the moment, but we do note the work that's ongoing, and in order to both strengthen our reporting of and our reflection of risk, and like you said, you know, just even in that last comment, to make sure that we're really explicit around you know, those high level risks and where we've got mitigations in place to minimize and reduce those risks. Yep, with that content. Okay, thank you very much. So the next item is our governance report, and back to Andrea.
Thanks, Helen. So this reflects the changes that we have made to board committee membership, given that we've had some new non-executive directors join us and some leave. So it's the position from the 1st of September, noting that we will have a discussion on governance on the 6th of October as a board, and this may well change after that, and once we have recruited into our additional non-exec director post, which will give us a little bit more capacity as well in terms of board committees. So it's present for now. It's likely to change before the next 12 months, and we'll bring it back at that point when that's confirmed. The work plan is included for the rest of this calendar year. We'll bring the 23-24 work plan after we've had the discussions in October, because that will move a number of items around on the work plan. So we'll do that at a later date. Thank you.
So we note and approve the two parts, but as a position, it is a point in time, very much. Okay.
Thank you.
Thank you very much. And then the review of board committee terms of reference, audit and risk committee.
So these were approved in July by the Audit and Risk Committee, and there are no material changes to highlight to the board. So we're looking for board approval for those.
Okay. We happy to approve them? Yeah. So we've then got our chair's highlight reports, and we've got all of the minutes of those meetings in the review room. So I'm not going to go through them one by one. Hopefully everything's been picked up, but I will ask if any of you who chair committees, if there's anything you want to raise from your reports or your minutes that you want to bring to the attention of the board from in terms of an escalation point of view. There's a bit of a speak now if I ever held your peace there, isn't there? No, that's marvellous. Thank you. There are then items in the review room, just to say, nice pictures in the CHS report. Learning Centre HRI looking really good. I thought that was a great report this time. And our final item was around our reflection around our one culture of care, which of course we had quite a long discussion earlier on in the meeting, and I guess it's just a moment's opportunity. If anybody had anything in terms of reflecting whether this meeting, you know, does what it says on its tin. Have we been nice to each other, apart from racing through a bit at the last minute? Have we exhibited our effective behaviours? Does anybody feel we haven't? Suzanne?
I think it's been a really good balance of the 3 Ps, Helen, as Brendan said, the people performance and the public pound. I think people have featured heavily on the agenda, which is great to see. And I think it's really important that we continue to make sure that there's workforce items that come and they are as important as other items. So from my point of view, I think that's a demonstration of one culture of care.
Okay, well, we'll take that as it is. Thank you very much. Thank you. So the date and time of our next meeting has moved. It's moved to Thursday, the 10th of November. Hopefully everybody has managed to clock that movement. And if there's any last observations from Gina or from Stephen, in terms of the public vote, anything else you would like to add?
Stephen, have you got anything to add?
No, nothing. Thanks, Helen.
I just wanted to say, as a governor, as a public governor, I've found it really refreshing today. I think the discussion has been high level, and I would agree totally with the 3 Ps. I think that's a really good way to encompass what has been discussed. So thank you for allowing us to sit in and for giving us the opportunity to see how much work you're all doing. And I look forward to meeting with you at various committees in the future. Thank you.
Okay, thank you very much.